Check, check. Hello. Hello. Hello.
Check, 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 check. Hello, my friends. Hello, my friends. Hello, 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 hello. Hello, mic testing, mic, hello, 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 hello. Hello, 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 check, hello, hello, live video. Hello, 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 check. Check, check, check.
check, check.
Hello, 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 check, hello, mic check, check, check.
shared commitment to continuous learning, professional growth, and the advancement of knowledge in this life. I would like to thank our distinguished speakers, panelists, and participants who have joined us from various places, lending their time and expertise to enrich. A special word of appreciation goes out to our organizing team whose tireless efforts have brought this program to life. So we'll all together make this event not only a successful one, but also a memorable and an enriching experience for us. So as you all know, interstitial lung disease pose a significant challenge to healthcare professionals as early detection and timely intervention are critical for improving the patient outcome. So there is an increasing need for the healthcare providers, particularly physicians and pulmonologists, to stay informed about the latest developments in the field of science.
As a part of our ongoing commitment to advancing awareness and building academic collaboration, we are organizing the Interstitial Lung Disease Sensitization and Awareness Continuing Medical Education Program under the aegis of ICMR's Network of Pulmonary Fibrosis in association with ACPDI Alumni Association. So now let's move on to the first session of the day, that is interstitial lung diseases, rising clinical challenge, for which I would like to call upon the stage the organizing chairman of the CME, as well as Professor and Head, Mr. Alok Nath, the podium. For the session, the chairs will be by Mr. S.P. Jindal Sir, Emeritus Professor, PGIMR, Chandigarh, the mentor of all mentors, Dr. Nikhil Gupta from API Lucknow, Dr. Alok Srivastav, consultant pulmonologist from Chandan Hospital, Lucknow, and Dr. Rajnish Srivastav, consultant pulmonologist from Max Hospital, Lucknow. Also, Professor Ved Prakash, the professor and head, Department of Pulmonary and Critical Care Medicine, King George's Medical University, Lucknow.
Guidance, the department has steadily growing and emerged as one of the finest centers catering to common and rare respiratory disorders in country. It is the first department to start here. Welcome.
Thank you, chairpersons, and good morning to everybody for having coming here to participate in this awareness and sensitization CME. I extend a very warm welcome to everybody, and this is a kind of awareness of sensitization CME which we have hold under the national network of ICMR's network of pulmonary fibrosis. And actually, this kind of CME and this kind of awareness program is basically the essence of the network, and which actually signifies the basic objective and aim of this network, which aims at creating the database for interstitial lung diseases across the country and sensitize all the healthcare professionals which are involved in diagnosis, evaluation, and management of interstitial lung diseases, which is a very complex and heterogeneous disorder. So to set the ball rolling, I will just give an introductory talk to start this CME, that we have a lot of challenges, or we have are undergoing a lot of challenges to in the diagnosis, evaluation, and management of interstitial lung diseases. Traditionally, ILDs have been classified into the idiopathic interstitial pneumonia group, the exposure-related, connective tissue disorder-related, granulomatous, and other miscellaneous groups. IIPs comprise the majority of interstitial lung diseases, and they have been further classified in 7 categories, and among which the newer classification shows some rare and unclassifiable subtypes also. For respiratory diseases, the prevalence of respiratory disease is around 26 per lakh population for females and 30 per lakh for males. Among these respiratory diseases, 15% is made by interstitial lung diseases, and as I told you, that idiopathic interstitial pneumonias comprise of the majority chunk of these patients, that is around 65%. From India, there is structured data available in 2 large observational studies, in which the famous Indian registry, which was published in the Blue Journal,
that is around 65%.
It was demonstrated that hypersensitivity pneumonitis was the commonest of amongst the all ILDs in across the India in all the centers, and and IPF and connective tissue disorders related ILD were second in the list. I mean, 54.3 among the IIPs, 54.3% has NSIP, whereas 31.8 had usual interstitial pneumonia pattern. But in contrast, the other large cohort, which was published in PLOS One, they demonstrated that hypersensitivity pneumonitis was not the commonest one, but the sarcoidosis were actually the commonest. This may be difference in because of difference in the recruitment or inclusion criteria and other factors. But hypersensitivity pneumonitis again also was comprising of a significant group, a significant part of the cohort. Risk factor for development of ILDs are age, male gender, and also genetically predisposed individuals, genes associated with telomere maintenance and surfactant production, common single nucleotide polymorphisms, reduced leukocyte telomere length. These are all genetic risk factors for development of interstitial lung diseases. Along with this, some ILDs like IPF, DIP, RBILD, PLCH, they are associated with smoking, air pollution, exposures, and underlying systemic autoimmune conditions. These are the various risk factors for development of ILD. The normal trajectory of a patient with ILDs, the natural history without any intervention, you can see in the black graph, black line. As you can see in this black line, that initial, there are, 3 stages: subclinical, asymptomatic, and symptomatic stage, which actually makes it very difficult for a person to recognize his or her symptoms, and even the healthcare professionals, for that matter, to recognize it in the early stage. And once the person comes up with some radiological abnormalities, even then the second stage, the patient may remain asymptomatic. But once he lands up with an acute exacerbation or lower respiratory tract infection, it becomes symptomatic, and later on it has a rapidly downhill course. But with interventions in various different kind of ILD, the trajectory can change, and the survival may be affected with the institution of management. So coming to the basic core of this talk, that what are the diagnostic challenges we are facing? There are various challenges, various hurdles or barriers to the correct, timely and correct diagnosis of ILD, such as non-specific symptoms at presentation, the insidious nature of disease, the heterogeneous nature of disease. I told you, as you have seen the classification, that it's a vast variety, more than 150 types of ILDs are there, which have overlapping symptoms, and there's considerable overlap with other diseases as well. There is limited access to chest imaging in developed nations, and lack of specialized interstitial lung disease centers, and availability of MDD, which has become the cornerstone for correct diagnosis of ILD. And finally, there is lack of awareness of this entity and the complexities of diagnosis and management of this entity. People know about ILD, but people do not know how complex it is to diagnose and how difficult it is, or how much credence should be given. ILD should be managed in a different fashion. Some surveys have been performed uh, address these questions, or address these barriers in systematic manner. And in a recent survey, it was seen that the patient had symptoms for mean of 10.5 months prior to their first visit to a respirologist or a pulmonologist. And prior to respirology referral, 96% patients had imaging studies, and 75% patients had already had spirometry studies, with a median of 2 chest X-rays per patient and 1 CT. And median CT from the time of median time from the symptom onset to the first HRCT was around 5 months. So this first HRCT from the onset of the disease was done at the 5 cent, and after that, about 2.4 months of delay was there. First referral, and a respirologist visit was obtained at 10.5. The commonest reported symptoms were dyspnea, followed by cough, fatigue, and etc. And the reason for referral was suspected ILD. So it was interesting to note that 15% of the referrals had no prior imaging done before sending them to higher center, and referrals, and it goes without saying that referrals who had had prior CT were triaged sooner than referrals who did not have any imaging done. This is the wait time for the CT in developing nations. It was ranging from 1.7 plus minus 1.6 months, and waiting time for a respiratory visit was lesser with the prior CT as compared to the with CT. 55% patients reported more than one misdiagnosis before the final diagnosis, and 38% reported more than two misdiagnoses before achieving the final diagnosis. These are the various entities which were actually put forward before actually the final diagnosis was done in the order of frequency, like asthma, pneumonia, asthma, bronchitis, allergy, so on and so forth. And the time lag from the onset of symptoms to the diagnosis was about 2 years in 30% of patients, then 3 years in 90% of the patients. And this is data from Western world. Such kind of structured data is not available from our country with this magnitude. But if this is the data from Western world, what is the thing? What is the whatever we are seeing is the tip of iceberg, and I think the things may be worse in developing nations. Delays in the diagnosis leads to delays referral and increased risk of complications. In studies, it has been proven that delayed referral increase the mortality in IPF. Delay in evaluation leads to delayed referrals for lung transplantation, and potentially resulting in loss of eligibility for lung transplantation as well. If somebody becomes ineligible because of advanced nature of disease and systematic deconditioning, he can lose the opportunity to get a lung transplant. And similarly, uh, 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 while the typical presentation of IPF mimics for other pulmonary disorders, they are uniquely responsive for unresponsive other agents. I mean, as long as you are not able to make the correct diagnosis, the correct treatment will not be taken. But things are improving as compared to the surveys done in 2000. First decade of this century, the this diagnosis was much higher than in this survey, and lately, in this survey, higher proportion of respondents had consulted more than 3 physicians compared with the previous survey. So things are improving. Healthcare setup or healthcare availabilities are being jacked up in the country and our state also. MDD forms the cornerstone or the gold standard for diagnosis, and it's nothing but sitting together with all the database and putting all the heads together with the help of pulmonologists, radiologists, pathologists, rheumatologists, occupational or environmental medicine experts, and sometimes the thoracic surgeons if the biopsies have been taken. And it is considered to be gold standard, and it increases diagnostic confidence, improves inter-observer agreement, and guides appropriate treatment strategies. And it should be performed for all patients suffering from interstitial lung disease. And it has been shown in longitudinal studies that it improves outcomes in various aspects in patient diet. But we have challenges that it is very resource intensive, variability in expertise, unclassifiable ILDs form a large chunk of patients with ILD. So we need to expand expand these MDDs. The barriers are people cannot be available for sitting together and discussing. So virtual AI, virtual multidisciplinary discussions can be done. AI tools can be inducted into so that we can improve the MDD discussion and the coverage of MDD discussion and integration of patient preferences into MDD based discussion meeting. So although MDD approaches improve accuracy in real life settings, challenges are there which lack because of lack of access and inconsistency in team composition, which are to be overcome by our own efforts and awareness and sensitization among the disease. These are some insights which we got from these surveys that a lot of patients, this is the patient's perspective, that patient found that actually he was not correctly diagnosed, and as soon as he reached a specialist, he was much more contented, and he found that if the primary care physician would have known about this diagnosis or about this entity is improper, I would have got the better advice. Like and in the when the patient is suffering from a disease and is all alone, he doesn't know how to go about or what will happen to him. So the patient response was that as soon as I reached the respirology unit, they inducted me a patient support group where I could discuss. I see the people were even more in a bad shape than me, and they could discuss their symptoms, and then they could find that this is the natural history of disease, and a lot of patients with interstitial lung disease are like these. These all things happen, and they can be. Our system also can be jacked up like this, and everywhere ILD support, ILD centers should be equipped with all these kind of things. And physician's perspective, that timely referral of the patient, radiological evaluation with patient that the symptoms, and people should be made aware that they should not ignore the initial symptoms, and if they have this kind of presentation, they should visit a chest care. These are the care gaps, that is the patient visit reviews or downplays and needs education. Alternative initial diagnosis are made. Awareness and sensitization of the healthcare professionals is important. Imaging, the access to imaging should be improvised, and larger patient with less of waiting time for imaging should be available. And then the radiologist's experience and expertise so that a correct interpretation of a CT or HRCT can be done. Then from the management point of view, which we'll be talking later. Coming to, these are the diagnostic challenges. Now coming to the management related challenges, there are the problem is that in ILD we have limited treatment options for the idiopathic group, and I mean there are various the diseases of a progressive nature without any effective treatment, so that with complications, various complications like progressive lung function decline, respiratory failure, pulmonary hypertension, and heart failure. Symptoms are difficult to manage. Pulmonary rehab is required for most of the patients, and we do not have access to these kind of facilities everywhere. Access to care for morbidities and pharmacological management. Coming to the treatment challenges, pharmacological management of idiopathic interstitial pneumonias is limited to very less number of agents which have limited treatment efficacy, and it has different response to different diseases. And currently, FDA approved agents are only two, that Pepinidone and Nintedanib. There are various issues associated with these drugs. Nintedanib is a triple TKI for management of IPF. Recently has also been approved or licensed for management of diabetes and BPF. The trials which gave us insight and beneficial effect of these when pulses, benefits, and inbuilt trial gave us some benefit with these drugs in various groups. But the problem is that it has got poor tolerance. Lot number of patients have various adverse effects and predominantly gastrointestinal. And there was a high discontinuation rate seen in clinical trials. While Nintedanib is an effective drug, but it does not stop disease progression, and there is the symptom improvement is not so significant, which is termed as MCID, that is minimal important or change of the difference in the amount of decline of lung function or the symptoms. Similarly, Pirfenidone, which is licensed only for management of IPF, is yet not licensed for management of progressive pulmonary fibrosis. There are some challenges with this, that this has got a poor adverse effect profile as compared to Nintedanib. It is even more poorly tolerated as reported by most of the users, and it does have some anti-inflammatory and anti-fibrotic potential, and is the most more experienced with this drug, and but unfortunately its use is limited by the adverse effect profile. And at times people may do argue, and we have experiences which we have shared, that they find Pirfenidone more effective as compared to Nintedanib, but the use is limited by toxicity profile. Coming to immunosuppressive therapies in ILDs, they are most of the majority of the ILDs have some or the other type of pulmonary involvement, but amongst them the systemic sclerosis, rheumatoid arthritis, Sjogren, and myositis spectrum ILD tops the list. And common drugs which are used for management are mycophenolate mofetil, the thiopurine, cyclophosphamide, rituximab, and other biologics like tocilizumab, and other immunosuppressive agents like tacrolimus, sirolimus as well. These are the various trials. So many trials have been done and are ongoing for management of connective tissue disease-related ILD, amongst which the notable ones like FAST study, the scleroderma lung study 1, 2, and 3, the Lotus study, the Senesis trial, and the trials on rituximab, which were positive trials, which showed the efficacy of immunosuppressive therapy like cyclophosphamide, mycophenolate, corticosteroids, tocilizumab, and antifibrotic therapy and systemic sclerosis ILD like the Senesis trial, which used Nintedanib. These are various trials, but amongst them, some notable trials have given us various insights into the management of connective tissue ILD, because it's very important, because only category, this is a larger category of patients in which immunosuppressive therapy has got a very effective potential for reversing the trajectory if picked up on right time. But at present, with the insights of all these trials, for IPF, it is contraindicated after the landmark Panther trial. In CTD-ILD, immunotherapy is recommended. In fibrotic hypersensitive pneumonitis, the recommendation is moderate. It should be done with case-to-case basis, depending on amount of inflammation assessed by various means, which we'll be talking in the later sessions. Undifferentiated ILD, it is not the efficacy is uncertain. It is not routinely used, but on case management and physician judgment, it can be used. And progressive pulmonary fibrosis, it is not generally recommended in multidisciplinary team discussions. At times, for symptomatic relief and short durations, immunosuppressive therapy have been tried in a small subgroup of patients with some benefit. There are various challenges which I've already told, that disease is of heterogeneous nature, and the outcome or the response to treatment is very variable, and the use of immunosuppressive therapy and glucocorticoids is limited by you require adverse effects, you require continuous monitoring. Older patient, it is more challenging, and it does not have a clear benefit in many of the ILD. So the misuse should be stopped or prevented, so that unnecessary complications due to treatment should be avoided. Coming to the non-pharmacological management, that is oxygen therapy, it is recommended, and all the data, all the recommenders have been actually extrapolated from the trials done in COPD. There are no structured large studies to find their efficacy in interstitial lung diseases. It is underutilized, and accessibility is a problem. Proven survival benefit in ILD patients have not been demonstrated, and the device which are difficult to carry along with the patient, because many times they need oxygen therapy continuously. So innovations in this field are important, so that it can be made easy for oxygen therapy to be given to all these patients, and they can carry along devices which are chargeable devices, or battery-run devices, or electricity-run devices, which can provide oxygen support to these patients. Coming to pulmonary rehab, cannot be underscored the efficacy or the role of pulmonary rehab in patients with ILD is of surmount and paramount importance. More in those patients who are being evaluated or being listed for being evaluated for transplants. But the adherence and access to pulmonary rehab is limited. So tele-rehab programs have to be instituted. Rehab therapy, which can be given telephonically, online, or virtual meetings, should be encouraged, and these kind of programs should be instituted. Although it has variable outcomes, but pulmonary rehab improves exercise capacity, dyspnea scores, and health-related quality of life in ILD. But these methods are less durable in patients with COPD. But because of lack of tailored protocols, we have all these shortcomings. But large, well-designed studies in this area might provide us insights in management of interstitial lung disease. Last but not the least is lung transplantation, and lung transplantation is coming up in a very strong way in the management of ILD. We have got so many eligible patients in our ILD clinics, but unfortunately, the access to lung transplant, the cost incurred in that, and unavailability in the public sector is a major hurdle. Only few private centers are doing it, and in India, from public sector, I've recently come to know that in Eastern India, in West Bengal, there are 1 or 2 hospitals which are doing it in public sector, and they started it. They have successfully done few of them, and they are doing it almost on completely on the expenditure of the state. So it is virtually free of cost therapy, which have been offered and recently started in Eastern India. But there are various hurdles: timely referral, timely identification of patients who are eligible for transplant. Many patients are eligible, but they have comorbidities and other factors which are hurdle for transplant, and global scarcity of the organs. which always remains a challenge in every area. These are the various things which I've just spoken about. There are various complications which ILD patients can suffer with osteoporosis, systematic deconditioning, muscular weakness, skeletal disorders. Pulmonary hypertension is one of the notable amongst them. That 30 to 50% of patients with interstitial deafness go on to develop pulmonary hypertension. Symptoms are same: exertional dyspnea, fatigue, and signs of right heart failure. And it has a very, very poor outcome on the effect on the impact of the outcome of ILD patients. Management is difficult, but there are some recent trials have come with some promising results. But still, because it constitutes group 3 PAH, the vasodilator therapy is not routinely recommended, but in some subgroup of patients, especially systemic sclerosis and other connective disorders, where out of proportion PAH is there, pharmacological management might be beneficial. Now, the new kid in the block is AI, and AI has really affected everybody's life, is started affecting everybody's life nowadays, but it has got a large say in the management of ILDs because automated pattern recognition on HRCT, quantitative imaging tools have come with a bang in the evaluation of CT and interpreting the pattern. And they have been found to be reasonably or even more accurate than trained radiologists as well. The consistency is, and speed and inter-observer variation, these all problems can be overcome by AI tools, and various tools are under the evaluation, that convolutional neural networks, radiomics, and integrative tools with integrate the clinical and radiological data and come to a diagnosis. So machine learning for early diagnosis and prognosis can be used, which can lead to early detection. It can also make prognostication models and subtyping ILDs as well. Role of AI is evolving in diagnosis, especially the diagnosis of ILD, and also in management. There are some of the key trials which have been done in the use of artificial intelligence in ILD, and it showed that AI may have a equal or better. Zafar is looking towards me that HRCT interpretation can be better or equivalent by artificial intelligence as compared to the trained radiologist as well. So the reproducibility of the data, the same person looking at the same radiology can pick up a different findings at 3 intervals. We make it a dictum that whenever we see HRCT patient, HRCT of ILD patient, we see it every time the patient comes to our clinic. Although we had seen the HRCT earlier also, and we always pick up something different, and we cannot remember all the findings, but AI can. If you feed sequential HRCT machines, it will give you a comparative report which is consistent every time. It will give the same. Whatever has been the machine has been learned, or algorithm has learned that learning of the algorithm has been done in which quality. Biomarkers, prognostication of ILD is of paramount importance because, as I told you, that a patient has to be, ILD patient have to be dealt in a different manner. Gradually he has to be told and about the disease, and he has to be, it has to be inculcated in his mind that this is a different kind of disease, this is the natural history of the disease, and prognostication is very difficult sometimes in these patients. Some work has been done for prognostication, apart from the prognosis which we know by the subtypes that this disease behaves in this fashion. But there are some blood-based biomarkers that KL6, SPD, SPA, CCL18, MMP7, YKL40, and other circulating fibrocytes. These have been evaluated in various studies, but there are, conclusive data has not evolved yet to say that one can have a very confident interpretation of these results. because of various problems, which are lack of standardization. There are various overlap between ILD subtypes. There is limited access to biomarkers in clinical practice because it is not available freely, and it has variable results in variable disease stages, and it has not been validated across a larger population groups. So, because we are running short of time, uh, I'll come to the final slides that we need for public awareness and education campaigns for ILDs. We need to educate our healthcare professionals for early symptom recognition. Educational materials for patients should be made available on websites, videos, YouTube, social media should be taken for into this campaign, and targeting general practitioners also is important to recognize this entity who could refer the patient to a specialist on appropriate time. Global campaigns like World Pulmonary Fibrosis Day to promote interstitial awareness, and for example, a Breathe Life campaign was focused for IPF patients, which increased the rate of early pulmonary referrals. But there are challenges that there is low public visibility, the terminology is complex, resources are less, and there is a digital divide that older patients may lack access to online resources. But in India, it is, as we are seeing, it is not correct. I think older population is using the social media more efficiently and devoting more time on social media than the younger ones. So there is a call to action for improved care and research by enhancing the access to multidisciplinary team discussion, promotion of AI-driven tools, expansion of public awareness campaigns, occupational and environmental regulations, investing in longitudinal clinical trials, and funding in genetic biomarker research. So to conclude, diagnosis of CTD remains complex, and it requires imaging, invasive sampling, multidisciplinary discussion to make a correct diagnosis. Emerging therapies like stem cell therapies are still in experimental stages. AI and biomarkers can be promising in various stages of management of disease, like treatment, monitoring, and prognostication. Lifestyle modification and pulmonary rehabilitation, exercise, they are very important component of ILD therapy, and public education and workplace safety for occupational diseases is very important. And we need more studies from the bench to understand the complex nature of disease. And I am sure that with, I mean, with so many people sitting together and putting their brains together like this, and further such kind of awareness campaigns will definitely make a difference. Thank you for your patient listening. Any comments and questions?
Issues related to the subject, you see, including the recent kind of use of artificial intelligence and other means, other devices or biomarkers in the diagnosis and management. So I think without going further, are there any, we will of course discuss the details of several of these issues in subsequent talks by different people. Meanwhile, I'll
Thank you.
Thank you, Dr. Alok, for such an exhaustive review of starting from the diagnosis to the role of So thank you. That actually excellent. Just one comment, sir. I think from a physician point of view, the major differential diagnosis for this is the cardiovascular diseases. And the slide which you showed about the delay in the reaching a respiratory physician. So that is somehow our training or whatever you can say that the investigation, the ECG is doing ECG is also doing easy and plus investigation wise, cost wise, it is much less than a CT. So that's, I think these are the delays. So that has to be, that delay cannot be taken care of until there is a massive awareness among the physicians, general practitioners, and even at the MBS level. I think.
I think only two things can clinch a diagnosis in primary vision because most of these patients come to a primary vision. Either he is trained to listen the fine grafts or there is a good quality X-ray, which is still a challenge when we moved out of this institution. Getting an
Sir, for
X-ray
the
in a
enriching
private practice
session,
which
now
can
it's time
detect
for the
early identity
felicitation.
changes is
I
still
would
a
like
headache.
to
So I
request
think with
Professor
advent of
Aloknath
AI, we
to
may
felicitate Professor
detect these changes early
S.K.
or
Jindal.
maybe may add a few quality years to patient's life.
Thanks, sir, for the enriching session. Now it's time for the felicitation. I would like to request Professor Aloknath to felicitate Professor S.K. Jindal. Professor Ved Prakash. Professor Ved Prakash and Dr. Alok Srivastava. Dr. Alok Srivastava. Dr. Rajin Srivastava. Dr. Nikhil Gupta. Now, I would humbly request Professor S.K. Jindal to felicitate the speaker, Professor Aloknath. Dr. Rajni Srivastava. Now, I would humbly request Professor S.K. Jindal to felicitate the speaker, Professor Aloknath. We conclude the first session of the day.
Moving to the next session of the CME for today, decoding the lungs.
Thus, we
Radiological
conclude the
patterns of
first
ILD.
session of the day.
To chair the session, I take immense pleasure in welcoming Professor Rajendra Prasad, eminent professor and head of
Moving to the next session of the CME for today, decoding the lungs, radiological patterns of ILD.
Next, I invite Dr.
To
Anand
chair
Kumar
the session,
Gupta, a
I
renowned
take immense pleasure
pulmonologist
in welcoming
Balrampur
Professor
Hospital,
Rajendra Prasad,
Lucknow.
eminent professor and head of
I
the
call
Department
upon
of Pulmonary Medicine
Dr.
in
S.N.
Iras
Gupta,
Medical
the
University,
senior most
Lucknow,
renowned
to the dais.
pulmonologist from Sanjeevani Hospital, Lucknow.
Next, I
to chair
invite
the
Dr.
session
Anand
and
Kumar
honor with your
Gupta, a
presence.
renowned pulmonologist in
I
Balrampur
welcome
Hospital,
Dr. Rachit
Lucknow.
Sharma, Associate Professor in the Department of
I
Pulmonary
call
Medicine,
upon
Era Medical
Dr. S.N.
University,
Gupta,
Lucknow.
the senior most renowned pulmonologist
Finally,
from
I call upon
Sanjeevani
Dr.
Hospital,
Rakesh
Lucknow,
Chaudhary,
to
consultant
chair the
pulmonologist
session
from Lucknow,
and
to
honor
chair
with
the
your
session.
presence.
So
I welcome Dr. Rachit
now I
Sharma,
welcome
Associate Professor
Professor
in the
Zafar
Department of
Niaz,
Pulmonary Medicine,
Professor of
Era Medical
Radiodiagnosis,
University, Lucknow.
SGPJMS, to kindly take the podium
Finally, I
and
call
share
upon
his
Dr.
expertise
Rakesh
on the
Chaudhary, Consultant
topic.
Pulmonologist from Lucknow, to chair the session. So now I welcome Professor Zafar Niaz, Professor of Radiodiagnosis, SGPJMS, to kindly take the podium and share his expertise on the topic.
If he can compensate some time, senior person can compensate, I know it. So, good morning. Although we started late, so I would request Jafar to, if he can compensate some time, a senior person can compensate, I know. More introduction when I am saying he is my. I don't think to this audience Jafar needs an introduction. I suffer from. He's a professor in Department of Radio Diagnosis. Every year he used to do. And more introduction when I am saying he is my radiologist also. Because I suffer from acute pancreatitis many times. Every year he used to do my MRI. One of the constraints in diagnosis is thoracic radiology. And he will be talking, as you know, that the way we see radiology is one, as you know, Alok has said very rightly, smaller hospitals, that one of the constraints in diagnosis is thoracic radiology. So nobody is especially the CT scan, the way we see, hardly anybody is following the way it is done in a smaller hospital, district hospital, even in a bigger hospital, even in a bigger center. So nobody is following, especially when we are talking on ILD, hardly anybody is following these guidelines, but it is available very freely. So I think
already
from
Dr.
this,
Aloknath has shown
I
there
invite
are
Dr.
a
Jafar.
lot of diseases which come
Thank you,
under
sir.
the spectrum
So
of
without
ILD,
wasting time,
and they have a
I will
variety of
start the
causes.
lecture.
So there are more than
So
100
already Dr.
ILDs across.
Aloknath has shown
But the problem is
there
that
are a
on
lot
the
of
CT, there are 4 or 5 important findings which are seen in all of these diseases. So lung has limited way of expressing the injury or the changes of lung injury on HRCT. So our problem is that from the HRCT finding, uh, diagnosing the cause or diagnosing the condition is very difficult because almost overlapping finding is seen in all of them. But anyway, we will try to, based on these findings and distribution of these findings, we will try to make sense and we will try to recognize some patterns. And the basic idea of recognizing these patterns is to differentiate between IPF versus non-IPF. So basically, as Dr. Alok has already shown, that the treatment and the prognosis is very different in the IPF group versus the other conditions like connective tissue disorder or chronic hypersensitivity pneumonitis, sarcoidosis, etc. So the major thrust in imaging is to identify the pattern, that is UIP pattern, which is associated with the IPF versus other patterns. So I'll be showing the findings in ILD. And as I already mentioned, the same findings can be caused by known causes like viral illnesses, drugs, or connective tissue disorder, as well as the idiopathic causes. So the findings may be quite overlapping, and only based on the radiology, it is very difficult to make sense of them until the clinical history and other lab parameters are corroborated. From imaging only, it is very difficult to make the diagnosis. So the most important finding which we report in our CT is the reticular thickening. Reticular thickening, there are a lot of crisscross lines. They are seen on the lungs, and they are associated with architectural distortion. Means they are not like the smooth septal thickening which is seen in pulmonary edema, but these lines are they disturb the normal architecture of the lung, and they can be fine or they can be coarse reticular thickening. So this is the most important finding which we see in most of the ILD, fibrosing ILD, I will say. So this is the first finding, that is the reticular thickening. So I have shown 2 slides, one which has a finer kind of reticular thickening, the other, as the disease progresses, we may have a coarse kind of reticular thickening. And another thing which is very commonly associated is the tractional bronchiectasis and bronchiolectasis, and it is usually associated with the reticular thickening. And in this we can see the bronchi which should be tapering and which should not be seen in the outermost part of the lung or the outer third of the lung, but still they are seen in the outer part of the lung. So this is called tractional bronchiectasis, and it only occurs in the areas where there are reticular opacity. They are not in isolation. So this finding, if you see the tractional bronchiectasis, this suggests that there is a fibrosis. Now, honeycombings are basically clustered cystic spaces with well-defined wall, and they are usually in subpleural location, and they are also seen in many kind of ILDs. So I'll be showing some examples later on. Now we have advances in the CT scan, and now we have volumetric data, and we can generate the coronal reconstructions from the axial slices. So sometimes we have a dilemma between whether this is a honeycombing or this is tractional bronchiectasis. So in those cases, we can make coronal reconstruction, we can trace the bronchi. So that sometimes may be helpful in differentiating honeycombing from tractional bronchiectasis, because if we label it as honeycombing, then our pattern is different, prognosis is different. So honeycombing is very important, but it is sometimes very confusing to say whether there is actually honeycombing or not. Volume loss also, in fibrotic ILDs, we may have volume loss. Now, not all ILDs are fibrotic ILDs. So far what I have shown is the features of fibrotic ILDs, but there are many ILDs which are non-fibrotic type of ILDs. Like in NSIP in the acute stage, the findings may be just ground glass. There are no fibrotic changes, but only ground glass finding may be seen in early stage of NSIP. Ground glass opacities are also one of the findings. But there are many causes of ground glass opacity. So we have to be careful while we are labeling these patients, because there are so many causes of GGOs. Consolidation. Generally, consolidations are seen in infections like in pneumonias or other causes, but there are some interstitial lung diseases like organizing pneumonias, eosinophilic pneumonias. They also have consolidations, and they are usually peripheral consolidation, and rarely sarcoidosis can also have consolidation pattern. So this is also a pattern which can be sometimes seen. Now coming to the mosaic attenuation, which are black and white areas on the CT, means some areas are black and some areas are white. And generally the mosaic attenuation is due to small airway involvement. But if there is background reticular thickening, means there is background ILD plus there are mosaic attenuation areas, then we think of chronic hypersensitivity pneumonitis. So this is an important finding which should be seen on the HRCT, because then we can suggest the possibility of chronic hypersensitivity pneumonitis. There are certain ILDs which are associated with the nodules like sarcoidosis, which have perilymphatic or peribronchovascular nodules, fissural nodules. And there are some ILDs like respiratory RBILD, which may have centriasinal nodule. So this is also seen in some type of ILDs. And also there are cysts, which may be seen in many fibrotic ILDs. We may see some cysts, but there are some ILDs like LIP or lymphocytic interstitial pneumonia, LCH, they can have multiple cysts. So cysts are also a finding seen in some ILDs. Now, coming to some additional findings, lymphadenopathy, generally some amount of lymphadenopathy is very common in many ILDs because there are inflammatory changes in the lung, and some amount of lymphadenopathy is usually associated with them. But if the lymphadenopathy is like very much prominent, or if it is necrotic, then we suspect something else. Like if the lymphadenopathy is the predominant finding, then we think of sarcoidosis. And there are certain interstitial lung diseases which have findings other than lungs, like pleural effusion, pericardial effusion, which are seen in connective tissue disorders, some drug-related ILDs. Sometime in scleroderma, we may have lung findings, plus there is dilated esophagus. And also in some condition like asbestosis, we may have calcified pleural plaque. So these are the findings which sometimes help in clinching the diagnosis. So we should, in addition to evaluating the lung, we should pay attention to these findings also. Now, once we have seen these things, another important thing is the pattern or the distribution of these findings. So if the same findings have upper and middle lobe distribution rather than lower lobe distribution, our diagnosis varies actually. So in UIP, usual interstitial pneumonia, we usually have lower lobe predominance, we have subpleural predominance, but there are certain diseases like sarcoidosis, hypersensitivity pneumonitis, inhalational diseases, they have upper and middle lobe predilection, and the bases or the lower lobes, posterior part of the lower lobes, they are spared. So this apicobasal gradient is very important, and it should always be assessed. Similarly, similar to the superior to inferior distribution, the axial distribution of the abnormality is also very important. So like in these two examples, in the first example, we see the fibrosis and there are some nodule also, but they are more in the central part, or they are more along the bronchovascular markings. While in the other case, they are more in the subpleural location. So again, in the first case, this was a chronic sarcoidosis, while the other case, the possibilities are like UIP or chronic eosinophilic pneumonia. So in both coronal plane and axial plane, we have to see the distribution of the disease. So far I have described all the findings. So what is the idea of describing all these findings is, the first thing is that we have to make up our mind whether we are dealing with a fibrosing ILD or a non-fibrosing ILD. Because if we have labeled it as fibrosing ILD, we have narrowed down our differential diagnosis to 5-6 important diseases like IPF, NSIP, connective tissue disorder, chronic HP, and chronic sarcoidosis. So these are 4 or 5 common findings in fibrosing ILD. So these are the signs of fibrosis. So if we have reticular opacities associated with architecture distortion, fractional bronchiectasis, honeycombing, volume loss, if these findings are present, then we say this is a fibrosing ILD. Like in this example, we see there is only some fine reticular opacities, sometimes may be confused with ground glass opacity, but you can see the tractional bronchiectasis actually. So that tractional bronchiectasis tells us that there is underlying fibrosis. So this is how we make up the diagnosis of a fibrosing ILD. Another slide. So we can see this first case is an example of fibrosing ILD. The other case also, lung is abnormal. There is a diffuse ground glass, some small cyst. So that is also interstitial lung disease, but that is non-fibrosing ILD. The first one is a fibrosing ILD. Now, after making up our mind whether we are dealing with a fibrosing or non-fibrosing ILD, another important thing is to identify whether it is UIP pattern or not a UIP pattern. So most of, because if we can make the diagnosis of UIP pattern, and then we need to correlate with all other things like patient age, history, any underlying connective tissue disorder, all other things, if they are all in taken care of, then we can make the diagnosis of IPF. However, UIP pattern alone doesn't mean IPF. It can be seen in other cases like rheumatoid arthritis or some other condition. So on imaging only, we can say this is UIP pattern. Whether it is IPF or not has to be clinically established by other clinical history and investigation. But since the prognosis is very different between the UIP and other causes, so on HRCT, we are trained to identify whether it is UIP pattern or not. So there are 4 categories on HRCT. The first is UIP pattern or definite UIP pattern, where we have all the findings which are suggestive of UIP. So these are reticular opacities, which are means fibrotic changes which are in subpleural, basal predominance, and honeycombing. So honeycombing is very important. So honeycombing and the distribution of abnormalities. So like in this example, we have honeycombing, we have reticular opacities, fractional bronchiectasis, and the distribution is more in the subpleural and lower lobes. So if we have typical finding, then we can say that on CT, this is UIP pattern. But there are difficulties sometimes because of presence of emphysema, presence of cyst or tractional bronchiectasis. We have difficulty in labeling whether there is honeycombing or not. So that is again a challenge. So another pattern is probable UIP. In probable UIP, you have all the findings that I have mentioned in the UIP, but honeycombing is not there. So again, Here, if all the clinical conditions are fulfilled like age and then the diagnosis of IPF can be made. But radiologically, we can just say that this is a probable UIP pattern and we have to investigate the patient further to for the treatment. So in some cases of probable UIP, we can see over, if we follow the patient, we can see the progression of the fibrosis and development of honeycombing. But whether in about, I think, good number of patients, they actually progress. Now, the third category is indeterminate for UIP. Here on HRCT, we have fibrotic lung findings, but we don't know whether it is UIP or non-UIP because neither they are like neither their distribution is typical nor they have honeycombing. So we have just fibrosis in the lung, but they are not subpleural predominance or there is no apicobasal gradient. So we can just say they are indeterminate. We don't know whether it is UIP or it is non-UIP. So this is one pattern. And another pattern, sometimes we have very subtle reticular findings. We can see in the lung basis, very subtle reticular findings. And we are not sure whether they are like early ILD or they are not early ILD. So that type of cases are also kept in the indeterminate category. And sometimes prone scanning is also used to see whether these opacities are dependent densities or they are actual opacities. So these two categories where there is fibrosis, but the distribution is atypical. And the other case is that where there is minimal fibrosis, we are not sure it is ILD or not ILD. These cases are kept under the category of indeterminate for UIP. Now, the fourth category is the alternative diagnosis, where we have abnormal lung findings. We are suspecting ILD, but there are some features which suggest that this is not UIP. So what are these features? If there are a lot of cysts, if there are multiple mosaic attenuation areas, there is too much ground glass, there are multiple nodules, there are consolidation areas, and if the disease is peribronchovascular in distribution, if the upper and mid lungs are involved, bases are spared, or there are other things like dilated esophagus, clavicle erosion, extensive lymphadenopathy, pleural effusion. So if we have these findings, then this is the ILD case, but this is not UIP. And in some of these cases, there are some findings in which we can suggest diagnosis also. Like if we have multiple areas of mosaic attenuation, we can suggest that probably this is a case of chronic hypercystic pneumonitis. While if it is a predominant cystic disease, we can think of LCH, LAM, LIP. Similarly, if there are a lot of ground glass areas, then could be an acute stage of NSIP. We might have multiple nodules, like in case of sarcoidosis. We can have consolidation in case of organizing eosinophilic pneumonia. So in these two examples, so the first example is a case where the fibrosis is a peribronchovascular fibrosis, and there are some nodules also. So if we see this kind of pattern, then we know this is not a UIP. So if we can confidently detect the nodules, then we can say this may be a chronic phase of sarcoidosis. But at least we know that this is not a UIP pattern. And also, if we see apicobasal distribution, the bases are spared, only upper and middle zone is more involved. So if we see, then we know this is not a UIP pattern. Now, another entity that is NSIP. NSIP is non-specific interstitial pneumonia, commonly associated with connective tissue disorder. But in some cases, there is no underlying connective tissue disorder. And again, the findings of NSIP and probable UIP, they are almost same in many cases. But in some cases, if we have subpleural sparing, like in this case, we have a subpleural sparing. So if we have clear-cut subpleural sparing and the fibrosis is somewhat more in the peribronchovascular distribution, then we suggest possibility of NSIP pattern. And as you can see in the UIP pattern, the findings are more in the subpleural location. So, but not in all cases of NSIP, we have a clear-cut subpleural sparing. So many times we are confused whether it is actually NSIP or probable UIP. That confusion is there. But if we have, and also in NSIP, generally honeycombing is not there. So this is how we differentiate between NSIP and UIP, but it's not always possible. Like in this case, we have fibrosis, and this fibrosis is has low predominance. There is tractional bronchiectasis. So based on the findings, we cannot say whether this is probable UIP or this is NSIP. But fortunately, we had a dilated esophagus and the history of the patient. So this was a connective tissue disorder related ILD. But on the imaging, it is very difficult to say whether it is an SIP or probable UIP. Another case, we have coarse fibrosis, tractional bronchiectasis in both lungs. There is no apicobasal gradient. And we can also see multiple areas of mosaic attenuation, or multiple, you can say multiple lucent areas. So whenever we see this finding, we suspect chronic hypersensitivity pneumonitis, which is quite common in our setup. So another case of hypersensitivity pneumonitis. So we have multiple areas of mosaic attenuation. And if the patient can perform an expiratory CT, these areas can be better appreciated. So this finding is very important and it should be noted on HRCT. Chronic stage of sarcoidosis, sometimes it can look almost similar to that of other ILDs, but usually the distribution in upper and middle zone, the bases are spared. There may be some nodules, there may be lymph nodes. So this is how we can make the difference between the chronic stage of fibrosis and other ILDs. RB ILDs, this is a non-fibrotic ILD. Findings are very subtle. We can only see some ground glass centri asinine nodules, and usually there is history of smoking. So findings are very subtle. And in smokers, sometimes we have a much severe involvement of lung in form of severe ground glassing and multiple tiny cysts. And this is a case of DIP or desquamating interstitial pneumonia. But these entities are usually seen in smokers. Sometimes DIP pattern we have seen in connective tissue disorder also, but usually we label them in smokers. Now coming to the organizing pneumonia generally it has multiple consolidations. Usually in the periphery, there may be other signs like atoll sign or the reverse halo sign, and sometimes these patients have consolidation in one part of the lung, and on the follow-up, that consolidation resolves, a new consolidation comes up. So this type of pattern, of course, this is a diagnosis of exclusion. So first we have to rule out the infection. But if we have proven that this is not infective, then sometimes it responds very well to steroid, and possibility of organizing pneumonia has to be considered. Sometimes we have this kind of pattern where we have all the findings of fibrosis, traction, bronchiectasis, but these are peribronchovascular. The fibrosis is peribronchovascular. So this is called bronchiolocentric ILD or airway-centric ILD. And this type of pattern we have observed in cases of organizing pneumonia, also in some cases of NSIP, sometime in chronic HP, also in reflux disease. So this type of pattern also sometime we encounter where all the fibrosis is along the peribronchovascular marking. So we might encounter this case also. Now I'll be showing some ILD mimics and then I'll be finishing my talk. So as we have all seen the COVID epidemic, and in the COVID cases also, the fibrosis is almost like any other interstitial lung disease. So that history is very important. So we still have to ask the patient whether you had COVID infection or not. But generally the COVID fibrosis is not progressive. And sometimes even we have seen that there is some reduction in fibrosis on follow-up in some of the COVID patients. But if we have only one study, it is very difficult to say whether it is post-viral fibrosis or this is ILD. So this is one mimic we have to be careful. And not only COVID, there are many other viral infections like influenza and other viruses. They can produce almost similar picture. Another viral infection, that is CMV, which we see in our renal transplant patient or HIV patient. And here also the pattern is almost like ILD. We have ground glass, reticular thickening, nodules, So again, only based on the imaging, it is very difficult to say this is CMV related pneumonia until unless we know the history of the patient and we have other investigation, it is very difficult. So if the patient is immunocompromised, then we also consider these possibilities. We just don't say that this is only ILD actually. Pneumocystis again, it can sometimes produce ground glass opacity similar to NSIP pattern. But again, the history is important, the history of immunosuppression, HIV patient. So then like this is a case of pneumocystis pneumonia. Sometime we may have fibrosis also in pneumocystis, we may have pneumatocyl. And this type of crazy paving pattern also we have seen in pneumocystis pneumonia. We have also seen in COVID patients. So this type of picture may also be seen, although it is classically described in alveolar proteinosis, but we have seen this type of picture in COVID as well as in PCP pneumonia also. And lastly, sometimes we have patients with vasculitis who have diffuse alveolar hemorrhage, and again, the findings are like ground glass and reticular thickening, there is subpleural sparing, and they may closely mimic ILD, but we have to know the history. So it is very important to know the clinical context and history before interpreting these cases. And coming to the conclusion, so first of all, we have to, whenever we are seeing a CT, we should know whether it is ILD or there are some other mimics, like as I mentioned, there is some viral infection, PCP, or there is a history of alveolar hemorrhage. And then if it is suspected ILD, then whether it is fibrotic or non-fibrotic ILD. And then on HRCT, we try to identify whether it is fitting with UIP pattern or not, or it is probable UIP. And if we have some findings like subpleural sparing, then we can suggest possibility of NSIP, or if we have mosaic attenuation, we can suggest possibility of chronic HP. So not in all cases we can suggest alternative possibility, but we have to describe the pattern in this way. And then of course the clinical team evaluates the patient to make the final diagnosis. So thank you very much.
Thank you, Jafar, for you have really decoded all the features of the ILD, what was required. Only one suggestion from my side, that as I see a lot of chest physicians, budding chest physicians are sitting, physicians are also sitting. So what I request, the quality of CT is very important if you really want to decode the various type of. So, and I also say, I have said at many forums, I'm saying it from last 10, 15 years, that it is the we chest physician, our physician, various type of, along with the radiologist, and I also say, I have said at many forums, I'm saying it from last 10, 15 years, there are guidelines that how the CT should be done in IL, especially in ILD. So I think with all your cooperation, as Alok said in his introductory lecture, that this is one of the issues that how the CT should be done in IL, especially in ILD. So I think with all your cooperation, as Alok said in his
For the
introductory
excellent
lecture,
lecture.
that
Just
this is one
add
of
one
the
or two
issues
things.
with
This is what
diagnostic
I'm sharing
diagnosis.
with my
So with this,
teacher, Professor
I
Radhikrishan,
asked Dr.
that
Hassan to say
see the
something.
advantage of this lecture is only with here
For
if
the
we have a
excellent
good
lecture.
quality
Just
scan.
add
If we
one or
don't
two
have the good
things.
quality
This is
scan,
what
and the good quality
I'm
scan
sharing with
means,
my
you see, we
teacher,
have to
Professor
request
Radhikrishan,
our radiologist
that
friend that
see
what you
the
have to do,
advantage of
what your
this lecture will
technician
only be
should do.
there
You see,
if we
unless
have
and
a
until
good
you
quality
guide the
scan.
patient,
If we
our
don't have the good
technicians
quality
guide the
scan,
patient that you have to do
scan means
this
we have
scan
to
in the
request
deep
our
breath, with a
radiologist
good
friend that what you
breath
have to do.
holding. You will not
What
get
your
a good scan.
technician
And when
should
you
do.
don't have
You
the
see,
good
unless
scan,
and until you
definitely
guide
you
the
will not be
patient,
able to appreciate
our
all these
technicians guide the patient that you have to do
radiological findings
this
of our
scan
excellent
in the
ICU
deep breath
human
with a
being.
good
Another thing
breath holding.
for
You
the
will
budding
not get a good scan.
pulmonologist,
And
that
when you
when
don't
it
have the
was
good scan,
suspecting
definitely
of
you will not be able to
interstitial lung
appreciate all
disease,
these
you should always
the
ask
radiological
and
findings
request
which
the
Zafar has very
radiologist friend
nicely
that you have
enumerated.
to do a
Another
prone
thing
images. You
for
have
the
to
budding
take the prone images
pulmonologist,
also,
that
because there
whenever
are
you are
many times you
suspecting
are confused that in the
interstitial lung
dependent part
disease, you
you
should
have
always
these
ask and request
type of
the
dense
radiologist
which
friend
are
that
the
you have to do
gravity
a
dependent.
prone
So
images.
to
You
differentiate
have to
whether they are
take the
really
prone
gravity
images also,
dependent, are
because
they
there
a
are many
part of the
times you are
interstitial lung
confused
disease,
that in
you
the
have to
dependent part
take a prone
you have have the these type of densities which are the gravity dependent. So to differentiate whether they are really gravity dependent or they are the part of the interstitial lung disease, you have to take a broad view. Only that will be able to differentiate. And I'll request all these pulmonologists that what he has told that every prescription you should write that whether you are dealing with a case of ILD, number one, you should dash it, and then you write whether it is fibrotic or non-fibrotic, and then again, which type of fibrosis, whether it is UIP, non-UIP, and then you can write your diagnosis if it is UIP, whether it is really IPF or you have the CTG related, whatever it is, the UIP pattern that causes. So that is what I message to give to young pulmonologists. Thank you.
What is sir, Rajendra Prasad sir and Gupta sir said that technique of CT should be clear. So my query is about that because the poor
Actually,
CT scan.
actually nowadays HRCT is the standard. We should not have that NCCT 3 or 4 millimeter cuts. We should have less than 1 millimeter cut, maybe 0.7 or 0.8 millimeter cut, number one. Number two, the field of view should be limited to the lungs. We should not have that NCCT 3 or 4 millimeter cuts. We should be highlighted less than 1 millimeter cut, maybe 0.7 or 0.8 millimeter cut, number one. Number two, the field of view should be limited to the lungs only. We are not interested in looking at other things. The lung should be highlighted, and then this reconstruction should be at a construction very sharp edges should be there. So there are three, four things. Technical thing. One is the of course you have to train the patient to hold the breath, and also because these patients have respiratory difficulty, we generally prefer to scan from below to upward. Because if we start from above to below, by the time we reach the lower lobe, the patient might take hold the breath because he's already having. So because these patients have respiratory scanning wise, we generally start from below scan from below to upward. Because if we start from above to below, by the time we reach the lower lobe, the patient might take the breath because he's already having respiratory problem. We have mosaic areas. Scanning wise, we start from below to above. And I think most of the of course, in some cases, whenever there is doubt of dependent density versus early ILD, then we do prone scan. If we have mosaic areas, then we should add the expiratory scans. And I think most of the scanners at present, they have HRCT available, and even 4-slice CT, they can have HRCT.
As Dr. Essen said,
I think the machine is not very important.
जितना मैंने समझा सीटी को अभी तक पिछले 20-25 साल में person doing is also as Dr. Essen said, हमने देखा बहुत जगह हिंदी बोलने थोड़ा सा कि उसमें लिखा है एक्सपिरेटरी फिल्म है, एक्सपिरेटरी फिल्म है नहीं, क्यों कहाँ गलती हुई टेक्नीशियन ने. Now the time has come, I believe, probably while you write a CT, especially in ILD, you must write HRCT. You don't need any contrast, especially in and then you have to specify full inspiration. When you say inspiratory, it is a full inspiration. When we see expiratory, it is a full expiration. So, and these guidelines are available on these guidelines. पर 35, 40, 45 वो फोटो लगाते हैं. जो लखनऊ शहर में भी देख रहे हैं और बस्ती गोरखपुर की तो बात ही छोड़ दीजिए, गोरखपुर वाले बैठे हुए यहाँ पे मैक्सिमम एक एक प्लेट पर 35, 40, 45 वो फोटो लगाते हैं. When guideline is saying very clearly, if you read ILD guideline, 9 to 12 maximum. अभी हमारी आंखों को देखना भी तो है. अभी जो जफर साहब ने दिखाया वो अपने अच्छे क्वालिटी वाले उससे दिखाया. खराब करोगे तो लिखना पड़ेगा. हम ही नहीं डायग्नोस कर पाएंगे तो हम दवा क्या लिखेंगे. तो that is a big issue I think in radiology. Probably all has to cooperate. और आप लिखते हमें शायद लिखना पड़ेगा. हमारे IMA के भी डॉक्टर साहब बैठे हुए हैं. अच्छा रेडियोलॉजिस्ट ऐसा नहीं इम्प्रूव नहीं करना चाहता. और अब तो यूपी के IMA में ये चीजें डॉक्टर साहब हमें कहनी पड़ेगी सही तरीके से. और रेडियोलॉजिस्ट हैज टू इम्प्रूव. अच्छा रेडियोलॉजिस्ट ऐसा नहीं इम्प्रूव नहीं करना चाहता. वो प्रॉब्लम वही है कि अब जैसे भी डॉक्टर साहब ने कहा कि एक्सपिरेटरी फिल्म भी होना चाहिए, प्रोन भी जहाँ जरूरत होना चाहिए. तो those things probably we have to specify to get it in.
हमारे सेटअप की बात है कि जिला अस्पतालों में DNB कोर्सेज भी शुरू हो गए हैं, तो इस तरह हमारा बहुत ही खराब है सिटी का। सर ने भी रिव्यू किया था हमारे अस्पताल में, लेकिन अभी इम्प्लीमेंट नहीं हुआ है। तो हमारे सेटअप की बात है कि जिला अस्पतालों में DNB कोर्सेज भी शुरू हो गए हैं, तो इस तरह हमारा बहुत ही खराब है सिटी का। तो मोड़ सर ने भी रिव्यू किया था हमारे अस्पताल में, लेकिन अभी इम्प्रूवमेंट नहीं हुआ है। तो मैं तो चाहूँगा कि सर की बात पूरे यूपी या इंडिया में सुनी जाती है, तो क्या हमारे जिला अस्पताल में इम्प्रूवमेंट आ सकता है? आज तो मोड़ तो यही है कि मैं सर से कहूँ कि वो फोरम पे आवाज उठाएं, जहाँ पे जिला अस्पताल में क्वालिटी HRCT की अच्छी हो सके। क्योंकि हम लोग सीख लेते हैं अच्छे स्पीकर से, जैसे डॉक्टर जफर से हमारे रेजिडेंट सब सीख रहे हैं, लेकिन जब करने की नौबत आएगी तो वहीं पे जीरो पे पहुंच जाएंगे। तो ये टर्निंग पॉइंट है कि जहाँ पर सर की आवाज वहाँ तक पहुंची। I just want to comment on the volume Rakesh Chaudhary's question, and then what I feel that is 16 slices scanner. If you have, that can do everything for HRCT. Only thing you have to follow the volume is the protocol, and then your technician should be able that and ultimately the reconstruction is there. You have to reconstruct and that have to reevaluate on the console only. Yes, so for HRCT, I think Zafar will also agree with me that 16 slice scanner is good enough.
Very good.
I think, sir,
Very good morning, all of you.
shortage of
Thank
time,
you, sir, for
so
a wonderful session.
should conclude the
As
session, sir.
in today's session, we have already learned that this is, disease, the ILD, is not basically is for the very good. Basically, very good morning, all of you, and thank you, sir, for a wonderful session. As in today's session, we have already learned that this is disease, the ILD, is not basically is for the clinician. It is basically a multidisciplinary approach. A good radiologist, we also need a good radiologist and a good clinician to diagnose these different types of ILDs. Thank you, sir. It was a very wonderful session.
Thank you, Jafar, and thank you, the organizer, for giving us this opportunity. I close this session.
Thank you.
Thank you. Professor of Pulmonary Medicine, SGBJ, to felicitate the speaker and the chairperson.
In humble recognition of your excellence, we offer this token of appreciation, sir.
First, I request Professor Zafar Nayars to accept the memento. In humble recognition of your
Please give a
excellence,
round
we
of
offer this
applause.
token of appreciation, sir.
Thank you. I request Professor Rajendra Prasad, sir, to accept the memento as a souvenir of our.
Please give a round of applause. Thank you. I request Professor Rajendra Prasad, sir, to accept the memento as a souvenir of our collective thanks.
I request Dr. Anand Kumar Gupta, sir, to receive the memento as a mark of honor.
I request Dr. Anand Kumar Gupta, sir, to receive the memento
To
as a
Dr.
mark of
S.N.
honor.
Gupta, sir, kindly accept this small piece of gratitude.
Next to Dr. S.N.
Dr.
Gupta, sir,
Rachit Sharma,
kindly
sir.
accept this small piece of gratitude.
To accept the memento as a small token of gratitude.
Dr. Rachit Sharma, sir,
Dr. Rakesh Chaudhary, sir,
to accept the memento as a
symbol of
small token of
appreciation.
gratitude. And to Dr. Rakesh Chaudhary, sir, to receive the memento as a symbol of appreciation.
We'll move on to the inauguration ceremony. Distinguished chief guests, respected dignitaries, and my dear friends, with great joy and pride, we welcome you all to the thematic CME on diagnostic evaluation and monitoring in interstitial lung disease here today. We are gathered to mark the
dignitaries
official
and my dear
inauguration
friends,
of the CME,
with great joy
which
and pride,
promises to be
we
an
welcome you
exceptional
all
platform
to
for
the
knowledge
thematic
sharing,
CME on
collaboration,
diagnostic
and innovation.
evaluation and
It's an
monitoring in
honor to have
interstitial
such a
lung disease.
distinguished group of
So we are
individuals
gathered
here
to
with us
mark
today,
the
and we are
official
grateful
inauguration
for
of
your
the CME,
time, energy,
which
and
promises to be
expertise.
an exceptional platform for knowledge
Now,
sharing,
without any
collaboration,
further
and
delay, I would
innovation.
like
So
to
it's an
welcome
honor
our
to have such
esteemed
a
chief
distinguished
guest,
group of individuals here with us
Honorable
today,
Director,
and we are grateful
Padma Shri
for your
Professor
time,
R.K. Dhiman,
energy, and
Professor
expertise.
Hepatology, to the dais. Now, without any further delay, I would like to welcome our esteemed chief guest, Honorable Director, Padma Shri Professor R.K. Dhiman, Professor Hepatology, to the dais. he has been
Professor Dhiman did his initial medical graduate and postgraduate program from
by the
KGMU
SGPGIMS
Lucknow,
in
followed by
last
DM
few years,
Gastroenterology from
and finally he
SGPGIMS.
has been awarded
He has
with
been
Padma
instrumental
Shri
in reaching
by
the
the government
highest
of India.
quality of healthcare by the
The
SGPGIMS
honor
in
just keeps growing.
last few years.
Let's welcome
And
Professor
finally,
S.K.
he
Jindal,
has
sir,
been
an
awarded with
Emeritus Professor
Padma
of the
Shri
Department of Pulmonary
by
Medicine,
the government
PGIMER,
of India.
Chandigarh, to the dais to grace us with his presence and join us in the inauguration ceremony. Let's welcome Professor S.K. Jindal, sir, an Emeritus Professor of the Department of Pulmonary Medicine,
Now I would
PGIMER,
like to call
Chandigarh, to
Professor
the
Vijay
dais
Hadda,
to grace us with his
Professor,
presence and
Department
join
of
us in the
Pulmonary
inauguration
Medicine,
ceremony.
Critical Care and Sleep Medicine, AIMS, New Delhi, to come to the dais.
Now I would like
He is
to call
also the
Professor Vijay
chairperson
Hadda,
of the
Professor,
steering committee
Department
of
of
INPF.
Pulmonary Medicine, Critical Care and Sleep Medicine, AIMS, New Delhi, to come
Finally,
to the
I
dais.
would like to call
He
up
is
on the stage
also the
Professor Alok Nath
chairperson
to
of the
initiate the
steering committee
inaugural
of INPF.
ceremony.
Now, as a mark of growth,
Finally, I would like
sustainability,
to
and
call
a
up on
greener
the stage
future, we would
Professor
like to
Alok Nath
welcome all
to
our
initiate
esteemed
the
guests on the
inaugural
dais
ceremony.
with a sapling by our welcome crew. Now, as a mark of growth, sustainability, and a greener future, we would like to welcome all our esteemed guests on the dais with a sapling by our welcome crew. I request Shah to give the sapling to our esteemed chief guest, Professor R.K. Dhiman, sir. Mrs. Usha to give the sapling to our esteemed chief guest, Professor R.K. Dhiman, sir. I request Ms. Poonam to give the sapling to our guest, Professor S.K. Jindal, sir. I request Ms. Poonam to give the sapling to our guest, Professor S.K. Jindal, sir. I request Ms. Vinita to give the sapling to our guest, Professor Vijay Hadda, sir. I request Ms. Vinita to give the sapling to our guest, Professor Vijay Hadda, sir. I call upon Ms. Pratibha to give the sapling to our Professor Alok Nath, sir. I call upon Ms. Pratibha to give the sapling to our Professor Lighting the lamp signifies the dispelling of darkness and the awakening of knowledge. It sets a sacred tone for the event, invoking wisdom, positivity, and clarity. Lighting the lamp signifies the dispelling of dignitaries on the dais to join in the symbolic ceremony. It sets a sacred tone for the event, invoking wisdom, positivity, and clarity. So I now invite our esteemed dignitaries on the dais to join in the symbolic ceremony. I request everyone to kindly stand in reverence for the prayer. I request everyone to kindly stand in reverence for the prayer.
Now I would like to call upon the podium Padma Shri Professor R.K. Dhiman to say some words regarding the
program and to address the gathering. Padma Shri Professor R.K. Dhiman to say some words regarding the program and to address the gathering.
Very much. Good morning. Sir Rajendra Prasad. Thank you very much. Professor Good morning. Jindal, my senior colleague when I was Professor Rajendra Prasad, PGI Chandigarh, my teacher. My batchmate Professor Jindal, my senior colleague when I was in PGI Chandigarh. Dr. Vijay Hadda, my batchmate Bhanu, Dr. Bhanu Pratap Singh, other colleagues, Dr. Vijay Hadda, head of the Department of the Pulmonary Medicine. First of all, I like to thank everyone Nath from the Department of the Pulmonary Medicine. Head of the Department of the Pulmonary Medicine. Particularly Alok. First of all, I like to thank everyone from the Department of the Pulmonary Medicine, and particularly Alok, but one of the most important who has invited me for this August function on the patient with the interstitial lung disease. And this is nothing but one of the most important things from the ICMR and many other things that you on the patient with the interstitial lung disease, I was doing ILD, my MD medicine about the diagnosis as well as the management and many other things also. We go to pulmonary chapter. When I was doing my MD medicine at King George's Medical College, you might get a case, and when we will go to the pulmonary chapters, so it was supposed to be one of the most important chapters that you might get a case during the examination also as a patient with the ILD. There are many causes, you all know about it. Patients, but my main concern is whether there is a role of the environmental factors poverty or the poverty group also. Because they are exposed to those different kind of the patients or the people who are the dust or the fumes or in the lower poverty or the poverty group also. They are exposed to the different kind of the environmental factors, be it the dust or the fumes or something else. Whether it is responsible for the increased prevalence or the incidence of this disease in this group of the patients or in group of the population, I don't know. Investigations also related to this. And we don't have public health related. I know about the ILD. I don't know. Investigations also related to this disease also. So that is something I know about the ILD. I would like to say. I don't know much because I am nowadays in a hepatologist actually. I like to congratulate Dr. Alok Nath for creating such a. Another thing that I would like to say. High quality, I would particularly excellent department. I like to congratulate Dr. Alok Nath. All the three for creating such a high quality, I would say the excellent department at the Sanjay Gandhi PGI. And all the three faculty was members by none other than the you can clap actually for this national renowned faculty or Professor Jindal and he also. Was trained by none other than the member Dr. Jia and the Asmal. They have also been trained from the PGI Chandigarh Pulmonary Department, and I think that was the first department in the country, Department of the Pulmonary Medicine and Critical Care from the PGI Chandigarh. So things are evolving, these things are spreading out, new departments are opening up. But I know about this department actually. The quality is extremely very high, I would say. Only 2 years ago they have opened the bronchoscopy lab, and they are doing all kinds of the procedures over there, whether invasive, non-invasive. They have pulmonary functions lab also. I think we have the state-of-the-art department of the pulmonary medicine at the Gandhi PGI. I must congratulate once again Dr. Alok and his faculty team, all colleagues for creating the same. Lastly, I would say, मुस्कुराइए कि आप लखनऊ में हैं. Lucknow is known for najakat, nafasat, and tehzeeb. So if you get some from this academic session somewhere, I think you must visit to the different places in the Lucknow also, like Bhul Bhulaiya, Darwaja. So many places are here to visit also there. And I think this is something very important that during the academic feast also, you should also relax. And at the last, I would, my best wishes to the whole team for the success of this event. Thank you so much. Thanks a lot.
Thank you so much, sir, for your kind words and taking out time from your hectic schedule. Now, I would like to call upon the podium Professor S.K. Jindal, who is the teacher of our teachers, to say something about this program and wishing success.
Honorable Director, Professor Bhiman, Dr. Hadda, Dr. Aloknath, Dr. Rajendra Prasad, and many other colleagues and friends and students, of course. Well, I have nothing much to say. I'm glad to say that this department is one of the excellent department of pulmonary medicine in the country, and ably led by Dr. Aloknath and his team, and not only the three, but even others who have joined subsequently. I think they have excelled in their performance. This program, of course, is an ICM, is under the auspices of ICMR, Network of Interstitial Lung Disease, which is a very important disease in the country, being recognized more and more. And of course, it is being kind of dissected for its causes, you see, because it is not a one disease. In fact, it is wrong to call it as a disease. Anyway, I'm thankful and grateful to be associated with this program, and thank you very much.
Thank you, sir, for your kind words. Now I invite Professor Vijay Hadda to kindly share your words of wisdom with us.
Professor Dr. Bhiman and Professor Dr. S.K. Jindal, Aloknath, senior colleague, and other colleagues. It's my honor to share this stage with this great people. First of all, I would like to thank the HPJ team who invited me here. The other thing is, I think ILD is one disease since maybe when we are resident and things look little easy to me at least. That all ILD were UIT, all ILD were IPF, and only 3 drugs, everyone needed to be protected. There was nothing to choose, and you keep on giving, and every time just the something. But for last 10 years or so, things have become little more difficult for us, but probably better for patient. That we have recognized that whatever we were doing for last so many years, but and subsequently there was one paper which was published from India, that the first India ILD registry, that ignite at least some thought that ILD is a real problem in India. And with that paper, I start thinking that we should do a little more about ILD. And as we read little more, then we come to know that we know very little. So with that idea, I approached ICMR that this disease is a rare disease, and most of the time the management is not properly created, and many times we are missing out. And I was lucky enough that DG ICMR agreed with me, and he proposed that okay, we'll start a task force on this project. And it was somewhere in I think 19, but then COVID struck and things were both delayed, and next 2 years we were like in like silent. But on paper this project was approved, and then somewhere in 2022 March the first center PGI Chandigarh approved, and then subsequently other centers also approved the main objective of this project was basically the capacity building. Capacity building means as a national coordinating team at United Sciences, then 3 coordinating center, regional coordinating center at SGPJ Lucknow, PGI Chandigarh, and CMC Vellore. We had a responsibility of conducting educational activities, and these activities were basically for the general physicians or younger colleagues, which were mostly dealing with ILD patient as a first-hand contact. So this was our objective, and with under this we have already done 3 workshops. One was conducted by Interstitial Medical Sciences. That was the first one. During that workshop, we prepared the diagnostic criteria and how to manage this patient, and we agreed upon and consent statement was made. Then subsequently, PGI Chandigarh and CMC Vellore, they did the similar kind of workshop, and we were able to train close to, I think, till now, more than 2,000 physicians will at least participated in these activities. If we combine all these 3 activities, and now I can see there are many people who are sitting here. I feel that the objective is being met. So coming back to this event, I would like to thank again Dr. Alok that he agreed to the ICMR's mandate that we need to conduct one more workshop on this, and he organized it in time. So thank you, sir, for that. And I also would like to thank the participants who have come here and they spared some time out of their holiday. So thank you, everyone. And with these words, I wish best of luck to Dr. Aloknath for this event. Thank you.
Thank you, sir, for your kind words. Now, I request Professor Aloknath to felicitate our Honorable Chief Guest, Director Padma Shri Professor R.K. Deeman, with a token of heartfelt gratitude and deep appreciation. I thank all the dignitaries on the dais for your gracious presence. Now, we humbly request the dignitaries to return to your seats in the hall as we move ahead with the next part of the program. Let's all give another round of applause for their wonderful contribution. Thank you, everyone. We'll move on to the next session of the CME, Unlocking the Deeper Insights of ILD. So to chair the session, I welcome Dr. BP Singh, one of the senior esteemed pulmonologists from Midland Hospitals, Lucknow. Next, I invite Dr. Pranav Ish, Associate Professor of Pulmonary Medicine, Vardhaman Mahavir Medical College and Safdarjung Hospital, Delhi. I invite Dr. Sanjay Tandon, the Chairman of API, Lucknow branch, to chair the session. I request Dr. Ashish Tandon, a renowned pulmonologist in Allahabad, to join the session. I welcome Dr. Abhinav Chaudhary, pulmonologist from Ayodhya, to chair the session. I welcome Professor Vikas Agarwal, Department of Clinical Immunology, SGPGMS, to take over the podium to share his insights on the first topic of the day, interpretation of autoantibodies in ILD.
Everybody, we'll be starting with this very important part of the CME, that is especially in the ILD interpretation. The interpretation of autoantibody has been very important, and we most of the time once a patient of ILD comes to us, we advise the autoantibody test. And to interpret it correctly, we need the expert advice of the rheumatologist. And to say that probably the best person is Professor Vikas Agrawal, the Professor of Clinical Immunology and Rheumatology at PGI. He is a graduate from KGMU and did DM in Clinical Immunology at the PGI.
He delivered the Zydus Oration of the Indian Association of Rheumatology in 2007 and prestigious IRA Oration in 2019. He has more than 250 publications in the national and international journals, including Annals in Rheumatic Disease, Lancet Respiratory Medicine, and Scientific Reports, as well as numerous book chapters to his credit. His area of interest include scleroderma, spondyloarthritis, vasculitis, mechanisms of drug resistance, and fibroblast and endothelial biology. And he was formerly the editor-in-chief of Indian Journal of Rheumatology since 2019 2022. So, Professor Vikas Agrawal, that is yours.
Respected chairpersons, thank you for your very generous and kind introduction. We're starting with the topic allotted to me, that is interpretation of autoantibodies, and this is very important also, especially for the youngsters who happen to come across a case of interstitial lung disease. And to start with the actual real life situation, I have selected a case that we have seen in our OPD. So this is a 56-year-old female who presented to us in 2023, but she had a history of 6 years. That in 2017 she started with cough without any expectoration or any other symptoms. She was a non-smoker, was not exposed to any smoke by burning coal or wood. In 2019 she developed progressive disease with progress from grade 2 to grade 3. But in addition, she never had any feature to suggest underlying connective tissue disease or any other condition. She attended our OPD first time in March of 2023. And at that time, when we evaluated her, we found that she had got a NSI interstitial lung disease, HRCD. Her 6-minute walk distance was limited, and she had a restrictive lung phenotype on a pulmonary function test. Echocardiogram did not reveal any pulmonary arterial hypertension. So we carry out the usual autoantibody test like anti-nuclear antibody, double-stranded DNA antibody, and extractable nuclear antigen antibodies. All were negative. So we were just debating, should we, because every time we see a patient, we want to economize the testing. But then we went ahead and asked for a myositis specific antibody. And we were not surprised when we could have a report of myositis specific antibody, that is PL7 positive. So this patient was initiated on mycophenolate, but she subsequently developed some infections. So it was ignored for a few weeks and then it was restarted. And this patient came back to us with an exacerbation of interstitial lung disease again in October. But it was managed properly, and till date she's doing fine with mycophenolate. So we came to a diagnosis of interstitial lung pneumonia with autoimmune features, or being a immunologist or rheumatologist, we made a diagnosis of interstitial lung disease with subclinical myositis and circulating antisynthetase antibodies. Actually, both being the same. Because patients who do not fulfill the criteria for a connective tissue disease can be categorized and are positive for autoantibodies along with interstitial lung disease can be categorized in this category of interstitial pneumonia with autoimmune features or IPF, and it overlaps with features of connective tissue disease, even IPF, or unclassifiable interstitial lung disease or chronic fibrotic ILDs also. So interstitial pneumonia with autoimmune features happens when the patient has got autoantibodies but do not fulfill the criteria to diagnose their connective tissue disease. Like a typical scenario is patient presenting with ILD and Raynaud's phenomena and has got an antibody positivity for SCL70 but no skin tightness or any other feature to suggest scleroderma. So these kind of scenarios we come across very often, and obviously rightly they have been categorized under the category of IPAC. So in 2016, the European Respiratory Society and American Thoracic Society task force was created, was classification criteria for diagnosing IPAF. And according to this criteria, it mentioned that patients of interstitial pneumonia, where the causes have been ruled out and they do not meet the criteria for a defined connective tissue disease, if they are having in addition to this features from a clinical domain, serological domain, or a morphological domain, which are listed here, can be classified as IPAF. Now, why do we emphasize on this classification for IPAF? Because when you have an autoantibody, that clearly means that patient believe inside the body is actually inflammatory in nature. Because autoantibodies are usually generated when you have a breaking tolerance to self-antigen. And for that breakage of self-tolerance, you need a good going inflammation. So there is a chance that patients who are autoantibody positive and ILD, if you give immunosuppression, they probably are will do better when they are treated with immunosuppressive medications. And I have been shown here the trajectory of survival of patients of interstitial pulmonary fibrosis versus patients with CTD-ILD versus patient with IPAF. So you can see the IPAF patients do better than the IPF patients, and they are more nearer to survival with CTD-ILD patients because they are being treated with immunosuppressive medications. So like in the case that I have presented, what is the implication of this myocyte-specific antibody which is present in a patient with IPAF? So this is a very good report published from Chicago, where they have actually, California and Chicago, where they have actually categorized in a retrospective data analysis of more than 1,500 patients, that patients who were having IPAF, when they were having associated myocyte-specific antibodies versus those who were not having myocyte-specific antibodies. So those who were not having myocyte-specific antibodies, they were having more of EYP pattern, HRCT, as well as surgical biopsy. And also, these patients tend to have rather poor prognosis as compared to the patients who were positive for myocyte-specific antibodies. And patients of IPAF who were myocyte-specific antibody positive, they were behaving in survival outcome as good as patients who were having inflammatory myositis-associated interstitial lung disease. So this has been shown here clearly in the survival curve that myocyte-specific antibodies are better in prognosticating the patient's outcome as compared to myositis-associated antibodies in a cohort of patients who are having IPF-like features. So why do we really want to conclude that patients have got IPF? There is a lot of debate on the outcome of patients who are initially diagnosed as IPF, whether they will always remain IPF or they will generate or go into evolve into some kind of a connective tissue disease. So various cohorts have reported sort of variable data. Some of them are saying that patients stay as such, whereas in a large cohort, it has been reported that up to 42% of the individuals with anti-synthetic antibodies and were diagnosed as IPAF later on developed myositis or RA or myositis or rheumatoid arthritis. So it's not that we need to patients not fulfill the criteria for an interstitial for a connective tissue disease or who are diagnosed as IPAF. Even in patients who are having connective tissue disease, it is good to know what is their autoantibody status, because autoantibodies can prognosticate patients' outcome much better as compared to their clinical scenario or others. So one of the common disorders or connective tissue disease which is associated with interstitial lung disease is systemic sclerosis. And here basically we have got two phenotypes, diffuse or limited systemic sclerosis. Diffuse one is more likely to be associated with interstitial lung disease, and the plethora of autoantibodies have been reported in this cohort, especially patients having positivity for anti-SCL70 antibody or patients having positivity for anti-U3 RNP antibodies, and these patients tend to have a poor outcome. In the centromere, in the limited systemic sclerosis, you have classical antibody, which is anti-centromere antibody, but it is rather protective for interstitial lung disease, whereas other antibodies like TH2, which are nuclear antigen antibodies, they are more reflective or correlating with pulmonary fibrosis in this group of patients. So let's look at what is anti-topoisomerase 1 antibody, seen in up to 40 to 50% of the patient with diffuse systemic sclerosis, and has got a high hazard ratio of odds ratio to develop pulmonary fibrosis. So any patient of systemic sclerosis with SCL70 positivity needs to be carefully monitored for development of ILD and should be treated as soon as the diagnosis of ILD is made. Otherwise, the outcome will be difficult or poor. Patients with anticentromere antibodies tend to have rather protection against interstitial lung disease, but they are worse because they are more likely to develop pulmonary arterial hypertension. Again, a very difficult situation to treat, and we do not have many pharmacological agents to treat this condition. Patients with anti-RNA polymerase 3 are rapidly progressive skin fibrotic patients, but they are rather protective for IND. So on one hand, patient will do bad because of the rapid progression of the skin and the other movement. But as far as the lung is concerned, they are unlikely to develop any interstitial lung disease. Whereas in limited systemic sclerosis, which we believe that is less associated with interstitial lung disease, if there is presence of TSTO antibodies, these patients are likely to develop pulmonary fibrosis. And again, these patients need to be carefully monitored during the development of interstitial lung disease. And as soon as there is any suggestion of development of interstitial lung disease, these patients need to be treated with immunosuppressive medications. Another complex that is a ribonucleoprotein C3 complex, which is anti-U11 and anti-U12 ribonucleoprotein, seen in patients with limited systemic sclerosis, is associated with pulmonary fibrosis. But the good thing is that it is very, very uncommon to see these autoantibodies in patients with systemic sclerosis. Patients of systemic sclerosis may be positive for PMSCF antibodies, usually seen in overlap with other connective tissue diseases. And this is a sort of a favorable prognostic factor because patients who receive immunosuppression, they do very well as far as interstitial lung disease outcome is concerned. Another autoantibody is again seen in patients with systemic sclerosis with overlap, and like PMSCL antibody positivity, these patients also do very well with immunosuppressive medications. Very, very rarely we can have ANCA antibodies, especially anti-myeloperoxidase antibody positivity in patients with systemic sclerosis. These patients tend to have features of vasculitis like ANCA vasculitis, but in addition, they also have more chances of developing interstitial lung disease. And again, if you have a patient of ANCA-associated systemic sclerosis, then this patient need to be carefully monitored for development of interstitial lung disease, even if he or she has not presented at the baseline. Then there are a lot of autoantibodies in systemic idiopathic inflammatory myositis. And myositis is well known to have a lot of associations with interstitial lung disease. So I'll be just focusing on some of the important ones. The most common antibody which is seen in a patient with inflammatory myositis is antisynthetase antibodies. So it's a group of autoantibodies which are directed against tRNA synthetases, against the histidine, threonine, and the other components of the amino acids of these tRNA synthetases. They typically present with mechanics hand, Raynaud's phenomenon, and arthritis, along with interstitial lung disease. The good thing about patients who develop these antisynthetase antibodies that they respond very well to immunosuppressive medications as compared to IPF patients. So this is the list of autoantigens against which this anti-RNA synthetase antibodies can be generated, and generally they show good response to immunosuppressive medications. It is a survival curve, one of the studies where they have shown that almost 70% of the patients are surviving at 10 years antisynthetase syndrome with IND, and compared to IPF, this outcome is much better, can be seen here. It is also reported that patients of inflammatory myositis who have Jo1 antibody, which is a versus non-Jo1 antisynthetase antibody. So the people who are non-Jo1 antibody positivity antisynthetase syndromes, they are likely to have poor outcome as compared to Jo1 antibody positive patients. Then this one very important autoantibody which everybody should be aware of, that is anti-MDA5 antibody. And this is melanoma differentiating factor 5 antibody, which was first reported in patients with clinically amyopathic dermatomyositis from Japan. And it was seen that some of these patients actually develop very rapidly progressive interstitial lung disease. So much so we have a very bad experience, especially if you really ask me personally. Many of our patients we have lost not even weeks but even in days after presenting to us with this antibody, despite treating them aggressively with all kind of immunosuppressive medications. So it can be seen that patients of MDA5 positivity develop rapidly progressive ILD and they have got a really poor outcome, and by the end of 3 years more than 50% actually die. Then another autoantibody which is very common, which is common in population but becomes very important when you have underlying connective tissue disease, is anti-Ro52 antibody. Ro has got two different autoantigenic sites against which antibodies can be developed. One is Ro52 and another is Ro60. Ro52 has been shown to be associated with severe interstitial lung disease when it is present in patients with connective tissue disease. And it can be seen that patients of Rho positive ILD, they do not respond even very well to the treatment as compared to those who are negative for Rho antibodies. Another antibody is SAE antibody, which is small ubiquitin-like modifier activating enzyme antibody and has been shown to be associated with interstitial lung disease, but especially in Asia and in Indians also. But the good thing is that these patients tend to respond very well to immunosuppressive medications. This is just a bar diagram to demonstrate what all kind of risks are involved when you have positivity in a patient with interstitial lung disease and myositis. Coming on to other connective tissue diseases like rheumatoid arthritis. So there is a positivity for rheumatoid factor and peptide antibody. And these are also sort of associated with the as a marker of interstitial lung disease, especially when both rheumatoid factor and anti-CCP are positive. So when you are seeing a patient of rheumatoid arthritis who is dual positive for both the antibodies, these patients again need to be carefully monitored for development of ILD at a later date. And if they happen to develop ILD, then these patients need aggressive suppression for treatment. A word about which is not there in the European Respiratory Society and American Thoracic Society guidelines for IPAP is the ENCA and the interstitial lung disease. Now, ENCA is basically associated with more of a vasculitic disorders. But if you see the emerging literature, you can see some case series where people have reported that patient can first manifest with interstitial lung disease as a predominant manifestation of ENCA vasculitis. So one should not ignore doing a ENCA testing also when you happen to come across a patient who predominantly presents to you with interstitial lung disease before you say that this patient do not have any autoantibody positivity. So this is my last slide. So my take-home message for the students here is that in a patient with interstitial lung disease without any full-blown connective tissue disease features, one should look for these antibodies: anti-nuclear antibodies, extractable nuclear antigen antibodies, rheumatoid factor, anti-CCP antibodies, ANCA, as well as myositis and scleroderma specific autoantibodies. Because positivity for any of these antibodies actually gives you a chance to treat this patient with immunosuppression and also gives a chance to the patient that he may have some kind of a better stabilization or rather improvement in his interstitial lung disease condition. So with this, I would like to thank everyone for their patient hearing. Thank you.
Thank you, Professor Vikas, for this excellent presentation on the autoantibodies in the ILD. As you have mentioned that actually most of the time we are asking for these panels in the routine practice because since these panels are usually available.
That actually
the
most of the time we are asking for these panels
in the routine practice because since these panels are usually available. The only thing we are missing in most of our practice is the asking separately for the myositis panel. And it is very important as you are suggesting in the diagnosis of the interstitial lung disease, you must have the myositis panel also.
Yes.
And what basically panel includes separately because most of the panel which are available in the market, they don't contain it.
See, there are 9 amino acids which are available for scientific antibodies. Some 13 against which antibodies can be directed. So in one go, you can see what all antibodies are positive in the patient. And depending on your interpretation of the patient's clinical condition, the radiological finding, and once you get the one positive, positive antibody, and many times then how much clinically it is relevant, it becomes difficult. So it is basically we do not have prerogative to have a person like you in the clinical practice most of the time outside. So what is your suggestion for that? Very simple, sir. First of all, 1 plus 2 plus ANA should not be given credence as far as IPF is concerned because the diagnostic classification criteria guideline mentioned that ANA should be positive at a dilution of 1:320 or more. So which corroborates roughly to 3 plus or 4 plus ANA positivity. It can be any pattern. It can be homogeneous, diffuse, speckled, nucleolar, or centromere. So don't worry about the pattern, but look at the dilution at which it is positive because this is the most common autoantibody that we ask for the first time. And also remember for all other autoantibodies, especially rheumatoid factor or anti-CCP, it should be more than twice the upper limit of the normal for that lab. If it is just say cutoff of CCP is 5 and it is 6 or 6.1, then it should not be paid too much attention. If it is more than 10, yes, then possibly it has got some significance.
So, I think for most of the patient forum which is sitting on here, that's a great insight that whenever you see a case of these vasculitis syndrome, autoimmune and connective tissue disorder should be evaluated to at least help the patient.
Just one question. In the first case that you showed, you evaluated the autoimmune profile without the myositis antibodies, and then you subsequently did a myositis panel. Any clinical or radiological hint or suspicion or which prompted you to go through it, or it was just like probably a female of middle age? Why would you go for?
So patient has presented to us in 2023 and she has history of since 2017, 6 years. In these 6 years, she never developed any feature to suggest connective tissue disease. So this was a learning for us also. So we first did ANA, ENA, and double stranded DNA, which came out to be negative. Then we were just debating whether to label as that idiopathic interstitial lung disease. But then I said, let's go ahead and do this myositis. There was no actually clinical proof to do this myositis specific antibody. So that is what I want to convey to the postgraduates here, that they should be, as a part of algorithm, they should be screening for myositis specific antibodies also. Thank you.
I have a lady, 38 and that that patient all the panels including any from private lab was negative. But as the symptom of the disease started, now the patient responded. How frequently can get this negative report and how to proceed?
Yeah, so it's a good question that how many patients who are actually maybe true IPF but do not have any feature autoantibody positivity. It may be there because all the autoantibodies are not 100%. So even if you see in SLE, up to 3% of the patients of lupus may not have ANA positivity also. And many times we do see such patients, and when we do kidney biopsy, then full house pattern actually gives us an idea that patient is having ANA negative systemic lupus. So you have to make a decision clinically at the end of the day. But in good number of patients, I would say more than 95, 98% patients of IPF, at least he will have some autoantibodies on it.
We are getting any such cases in our clinical practice in private sector. So is there any assistance from your side that you can provide to us? I mean, in such cases where we are getting negative report and clinically
we can only provide assistance if patient comes to us.
So I think if there are any questions from the audience, one or two questions we can take. Of course, we can. Thank you. If there are no questions, wind up the session. Thank you.
Thank you, sir. Your thoughtful and in-depth sharing of knowledge today was beyond valuable. We are grateful for your contribution and the rich perspective you brought to the discussion. I welcome Dr. Nitesh Gupta, Associate Professor of Pulmonary Medicine, Vardhman Mahavir, Medical College and Safdarjung Hospital, Delhi, to share his views on the topic, Invasive Diagnostics in ILD, Practical Considerations. I request the Honorable Chairpersons to introduce the speaker.
So I think I'll take that honor. So Dr. Nitesh Gupta is a faculty of pulmonary medicine at Safdarjung Hospital, Delhi. He is a co-faculty with me. He has done DM from Safdarjung Hospital and an MA from Maulana Azad Medical College for UG and Patel Chess for PG. He has around 250 plus publications and he has been teaching since many years. He has been teaching me since MBBS days. So I welcome Nitesh sir to take the topic invasive diagnostics and ILD, some practical considerations.
Everyone. First of all, to begin with, I will thank the team at SGPGI, along with collaboration with ICMR, for inviting me for the talk. So invasive diagnostics in ILD is something which is now coming up, which has been there but has now picked up in a big way, primarily because now it is a part of most of the diagnostic algorithms, which was not there earlier. The unique challenge which an ILD patient presents to us is the physiology. Having ILD, lower lung volume, lower FRP, lower oxygen reserve. So anytime you touch or enter their airway, you will have a rapid fall in desaturation and you will have more complications if the procedure is not well planned at the early. So clinically we evaluate the ILD, as Karan also said. We do the symptoms, we look for associated history, we look for signs, we look for radiology, and after serology we sit in an MDD to decide whether we are able to fit the patient in one of these boxes or we are still missing something to make a patient fit in any of these boxes. So this is the latest classification of ILD. The blue part suspects that which of the diseases is likely to move into the progressive pulmonary fibrosis. So this was the ATS classification where UIP pattern, IPF pattern has taken a predominance. When if you find a UIP pattern or a probable UIP pattern, you are not likely to proceed with anything further and you start the patient on antifibrotic. But if you have your indeterminate for UIP or the alternative diagnosis, you need to move into the next step. Why? Because typical UIP on radiology has a positive predictive value of 90 to 100%, but HRCT may miss up to 60% of pathological UIP cases. That is why it is important to keep the invasive armamentarium in your loop. So this is the latest flow diagram, a lot of change from the earlier one. So if you have indeterminate for UIP or alternate diagnosis in the radiology pattern, you move, do an MDD and move in one of the invasive methods, either BAL plus minus transbronchial lung biopsy or a surgical lung biopsy depending on the center expertise, the patient's profile. So going to the very basic, so bronchoalveolar lavage, again not a lost art, something. It is not that interventional pulmonologists should not know what a good BAL is. So you should not forget how to do a good BAL because it was earlier said it could only resemble non-specific patterns consistent with or suggestive of the normal BAL fluid, and it used to have a differential. Like if more than 15% lymphocytes, then it was lymphocytic pattern, more than 1% eosinophilic pattern, and it's all differential diagnosis. But in current era, if you have to diagnose hypersensitivity pneumonitis, to have at least a high confidence, you need at least a BAL lymphocytosis. When a CT pattern is recognition of HP, you need at least a BAL, and if you have to be definite, you need both a BAL as well as the biopsy. Transbronchial lung biopsy again has been there for longer time. yield varies widely, 25 to 75%, primarily because of two factors. The one of the disease, IPF, has a low yield of 20 to 30%. The other non-fibrotic IIPs have a higher yield, about 80 to 90%. That's why an average comes about 25 to 75. The problem with transbronchial lung biopsy is the crush artifact. You have lot of crush artifact and you just get a size of 5 mm of a peak. Where it is likely to succeed, it is likely to succeed in a peribronchovascular or a central lobular involvement on radiology, like in sarcoidosis, hypersensitivity pneumonitis, eosinophilic pneumonias, or organizing pneumonia. So these four are likely to give you a positive result as compared to other IIT. Surgical lung biopsy, again, has been there for long, but the problem is your patients are too sick, a procedure is cumbersome, and so mortality outcome just with the diagnostic criteria is high. So we have the meta-analysis published about 10 years back, about 2,500 patients were there. IPF was the most common diagnosis. Again, if we see diagnostic yield varies, somewhere between 40% to somewhere between 100%, despite having a surgical lung biopsy. And post-operative mortality rate was higher, it was about 3.6%. So then comes the I stage. What do we do so that we have a better diagnostic yield and lowest complications? So this was one of the earliest paper on transbronchial cryobiopsy for DPLD, basically. So this was the earliest paper which had 41 patients, had shown that DPLD is a safe procedure, has a biopsy size of more than 3 times that of forceps, and is able to increase the diagnosis by about 15%. So this was about after 10 years the first paper, then came how should the method be evolved so that it is standardized globally. So this was the working group which sat in 2018 and made the procedural standardization protocol in what is the role of TBLC in diagnostic evaluation, where should we fit the patient, how the histopathology should be read, what are the contraindications, who should perform it, where should it be performed. So they had given the indication primarily DPLD which requires your tissue diagnosis. So somewhat again by radiology where we have indeterminate pattern or a pattern which is not fitting into any of the criteria. Contraindications for cryobiopsy are very simple. You have hemodynamic instability, you have bleeding manifestations, patient is on anticoagulant, or platelets are less than 50,000. Relative are pulmonary hypertension, you have very low FBC of less than 50%, or your DLC is less than 35%. These are the patients where the contraindications are there and you should take the patient seriously. So 4 years from it, we had a systematic review for the amount of data which was generated, and diagnostic yield was about 82% with 30%, which was still high considering the amount of the cases which were being done. Then this study only gave us the diagnostic yield. We were not able to calculate the diagnostic because direct comparative trials with surgical lung biopsy were not there. So then came the coldest to the rescue. This was a trial which had 2 arms. One was surgical lung biopsy and one was just the cryobiopsy, which has shown that there is a concordance between the surgical lung biopsy and the cryobiopsy, both for IPF and hypersensitivity pneumonitis and other idiopathic interstitial pneumonia. So post 2022, we had 2 more trials which showed forceps versus cryo versus laparoscopic thoracoscopic lung biopsy. The chill study, again, it showed transbronchial lung cryobiopsy has concordance with surgical lung biopsy. Then came the CANICE trial, multi-center, multi-agreement trial. Again, MDD was involved in this, and it showed that when you have a transbronchial cryobiopsy with MDD versus surgical lung biopsy with MDD, they agree to each other. But we wanted more data and we wanted more RCT. So this was the RCT which was published last year, where you do an upfront transbronchial cryobiopsy in one group versus an upfront surgical lung biopsy in the other group. The add-on strategy which was used in this trial was, if your transbronchial cryobiopsy did not have an yield, you do go for the step-up surgical lung biopsy. So the results clearly showed diagnostic yield was about 82%, even after transbronchial cryobiopsy alone, which was not significant with the surgical lung biopsy. And it became the matter, it got introduced into the guidelines that wherever required and expertise is available, transbronchial cryobiopsy can be done instead of a surgical lung biopsy. Then, but is diagnosis good enough? Is my cryobiopsy or is my biopsy of the ILD patient, which I am doing under a high risk, is it changing the treatment? So this was the study which was published 3 years back, in which it showed when on the left side, when there was a biopsy report available, straightforward 20% of the people have change in diagnosis in the orange column. But if there was biopsy was not reclassified after, they were not reclassified after the biopsy, but after the MDD they were reclassified based on the confidence level. So overall, 4% has change in diagnostic treatment. That is when patient had more of UIP pattern, they were shifted to IPA, they were shifted to antibiotic. Those patients who had inflammatory pattern, they were shifted to immunosuppressive therapy. Did it change anything? Yes, it definitely changed a lot of things, especially the gray column. When patients were shifted from IPF to non-IPF category, the survival improved. So this was the change which brought about that why the biopsy is important, and it also has a problem. It also has something to do with the treatment strategy also, and it should be incorporated in the algorithm. Then another invasive strategy, the something which is now picking up very well in the country along globally, is mediastinal cryobiopsy. We were fortunate enough to be part of the first paper from India when a case report was published, followed by 2 more papers where they were studied either as a patient who had inadequate role or as an upfront modality of the mediastinal cryobiopsy. It had shown higher yield as compared to about in TBN about 20% in benign disorders. Malignancy, there is found to be no change, but benign disorder like sarcoidosis is one of the commonest INDs in India, among with hypersensitivity pneumonitis. So if mediastinal cryobiopsy is done for sarcoid, we have a higher chance of about 14-20% to have a diagnosis straightforward. Since lot of evidence came, 2 systematic reviews were published on the same in the same year. Both had shown that about 20% yield was higher in benign disorder. Then, since lung transplant is picking up in India, we need surveillance bronchoscopies and surveillance biopsies to detect early graft rejection. So, does a cryobiopsy favor us more than the forceps biopsy? Last year, we had 2 RCTs and both have shown that upfront cryobiopsy with 1.1 mm probe detects allograft rejection much better and earlier as well as chronic rejection than the standard forceps biopsy. So this is something which will have indication in another 2-3 years in our country as more and more transplants keep picking up. The no talk is complete without introducing artificial intelligence in your presentation. So for interstitial lung disease, there was a genomic classifier by NVIDIA, which basically was done by the BRAVE study where they had surgical lung biopsy and they derived the transcriptomic signatures from microRNA of all those from those surgical lung biopsy patients who had IPF, and then in next part of the study, all those transbronchial biopsies which were done, they run the same mRNA signature on the study. So it has the machine learning method where it gathers a lot of information from your surgical tissue and develops into a pattern which tells you whether this is IPF or it is a non-IPF. 2 years later, it has now been extended to other diseases also. For UIP pattern, the sensitivity is 60, but specificity is about 92%, and positive predictive value is again 92% when you use the genomic classifier. So the graph on the left shows you before NVIDIA genomic classifier, you had only about 30% of IPF, but after incorporating NVIDIA genomic classifier, the IPF prevalence has increased to about 60%. What has reduced is unclassifiable ILD. So you are able to classify ILD into one of those boxes rather than leaving into unclassifiable. Same thing happens with your diagnostic pattern. The confidence is again increased on the right side of the graph. Again, systematic review and meta-analysis of the 4 studies of NVIDIA genomic classifier had shown a high specificity as well as high sensitivity in detecting interstitial lung disease. So is there something futuristic? Well, not exactly futuristic, but we'll see more roles of it now. Optical coherence tomography, one thing, it has been there in cardiology where they look for the vascular structure as a non-invasive modality. So how is it different from a radial ultrasound? It is basically based on near infrared technology where scattering of light is the phenomena as opposed to radial ultrasound where reflection of the light is phenomena. So advantage is you do not need a transducing medium or a contact with the airway to produce the image. So this is how the image on the top is of the airway where through the bronchoscope optical coherence tomography catheter is inserted. and below is the vascular OCT, which has been there for long. So it also delineates all the structures. It has been studied variably in the clinical data. About 41 patients were there, where it has a concurrence with the histopathological diagnosis in about 87% of the cases. So this is something which we will see in future coming more and more. Second futuristic technology is conofocal laser endomicroscopy. It is basically, in short term, said as a live histopathology, not in a colorful method, but in a black and white method. It is again a guided catheter inserted through a bronchoscope or a thoracoscope, which goes into the tissue, gives the light of about 600 micrometer, and the reflection is observed, and it produces images of each structure in a black and white method. So as we can see, we can identify the structure and look for the disease patterns. Again, it has been again evaluated in the clinical study where diagnostic accuracy with the cryobiopsy was about 82%. It can help us identify the biopsyable area so that we have less chances of pneumothorax, because it will tell us how far we are away from the pleura, which will again obviate the need of using a fluoroscopy at the scene. This was the clinical study where again about 30 patients were evaluated and these various patterns were identified. In the end, summarizing my whole talk, DPLD's early diagnosis is essential along with the management, because it has a high morbidity, high mortality, not only in the Western data, in our country also, as the data has been emerging from previous studies, and as INPF data will come out, we'll get a lot of clear picture into it. Transbronchial lung cryobiopsy is a safe alternative in an expertise hand in a well-experienced center. Future, we are looking for bronchoscopic modalities for diagnosing ILD, which are non-surgical and less invasive, and may potentially obviate the need of histopathological biopsy specimen. Thank you for your kind attention. Anybody is interested in the slide set can mail me. Feel free to share to anyone.
Thank you, Dr. Nitesh, for the excellent presentation. Actually, it is the way forward in the management of the institution. In India, still we are lagging far behind in having basically the tissue diagnosis, and even the IIT India has shown very dismal figure of around 4% of the patient having this histological diagnosis. And another very important point he has made, actually we are still relying in the histopathology, age-old technology of 1877 discovered by the Russian scientists of the HE staining of diagnosing the histopathologically the pathological specimen. Now the Invisia genomic classifier, as you have mentioned, with the advent of the introduction of this AI tool, you are able to identify these patients much more precisely of this, whether you are dealing with IPF or non-IPF. Only problem with Invisia is that all the sensitivity is very high. Sensitivity is low, 61.1%, while the specificity is very high, around 90%. So probably we need to evolve further on this thing, whether we can use it in future, because we have to improve in the specificity of sensitivity also. Right. So many other things are coming up in the future, but only thing is that still we are lagging. We have to do routinely the transbronchial lung biopsies where it is indicated. We have to increase more number of centers to do the cryo lung biopsy. Although we are learning and although we have been doing these procedures, but the consent from the patient is also very low. Actually, once you start explaining the complications of the biopsy, most of the patients, especially in the private sector, they don't agree for this procedure. But I think it is much better in the government sector, where you can use much rather more assertive approach to have the biopsy. So I think this is the thing which is for the futuristic, and we have to start with the routine biopsies in our patients with ILD, where it is the indeterminate, and we are not able to prove that what type of ILD it is. If there are any questions from the audience, yeah, Abhishek.
Thank you so much, sir, for the talk. I just wanted a comment. Is there any guidance available as to which size of a cryoprobe should be used to attempt the cryobiopsy in a DPLD patient, or it depends upon the preference of the physician?
So they have now shown that 1.1 mm cryoprobe data is equivalent to 1.7 cryoprobe. It is equivalent. Obviously, larger the tissue you give, the better the histopathology will be. But again, the more the chances of complication. So now they say 4 pieces with 1.1 cryoprobe are good enough to achieve the diagnostic accuracy about 89-90%.
think we'll close the session. Excellent. Okay.
Thank you, sir. Your in-depth understanding and explanation has made this session incredibly enlightening. Moving to the last part of the session, I request Professor Vijay Hadda, Department of Pulmonary Medicine and Sleep Disorders, AIIMS Delhi, to the podium to share his insights on the topic functional assessment in ILD. I request honorable chairpersons to introduce the speaker.
I LPF chairman of steering board. Respected chairpersons, thank you for your kind words. So, continuing the topic further, previous 3-4 talks have already told that what is ILD, how to diagnose, and what is the role of getting biopsies. But one of the important thing is, once we have diagnosed ILD, the next step will be how our patient is. Meaning thereby, what is his functional status. So to assess that, there are certain tools which are required. And unless we know that functional status, it will be very, very difficult to decide what will be the best approach for maybe diagnostic algorithm or maybe therapeutic algorithm. As he has already told that there are, although lung biopsy can be very helpful, but unless we do a functional assessment with the help of physiological test and tell that this patient is not fit enough for getting any kind of tissue, then it will be a great mess. So, meaning thereby the functional assessment, all the ILD is very, very important before deciding further approach. So what exactly what we do during functional assessment? It will help to evaluate the disease severity. It will also help to monitor the disease progression. Based on this, we decide the treatment decisions, and it also assess the impact on the quality of life by the ILD, and it also helps in predicting the outcomes. There are many tests which can predict the mortality over short term as well as long term, as well as other complications, for example, risk of exacerbation requiring hospitalization. So broadly, if we see the functional assessment, we can use these tests, which include the pulmonary function testing, which we will discuss later on. We can assess the exercise capacity, which can be done with at least 2 tests. Then there are different dyspnea scales, which assess the severity of dyspnea, then quality of life questionnaires, and then some imagings. I think last part I will not discuss. So the pulmonary function testing, as a pulmonologist, all of us are aware that forced vital capacity and DLCO, these are very commonly used diagnosis as well as monitoring the disease. In some centers, maybe DLCO may not be available, but spirometry is available in almost all the pulmonary centers. So this can be very, very useful, although there are some limitations, but still, forced vital capacity is one of the important tests which is required. If we talk about FVC overall, it may not be very specific, but it supports the diagnosis of ILD in a correct scenario. If you are suspecting that this is ILD and then you see that restrictive pattern is there, the spirometry and FVC is also reduced, then it supports the our diagnosis of ILD. If we monitor serially, then it can give the information regarding how the disease is progressing. And there are studies or multiple data which have supported a cutoff of more than 10% of this predicted FVC to indicate that there is a significant progression over the spirometry. So as we discussed, it can be baseline. So if we do a baseline FVC, as the less FVC, there are more chances that patient can have a adverse outcome in the future, maybe mortality. Also, if there is a larger decline, there will be worsening of symptoms, higher hospitalization rate, mortality rate, and also the FVC is very useful to the few of the indices. One of the important indices is gap index, which we will discuss in further slides. So FVC is very, very important test. There are data which have suggested that if you do the FVC today and then you follow up with patients, and change in FVC can predict death over next 52 years, 52 weeks, or that means 1 year. So there may be scenario where the FVC can increase or FVC can decrease. There are only few diseases where FVC you expect that ILD patient the FVC will be increasing, but most of the time it will be decreasing. So every decrease in unit of FVC, you can predict that what is going to happen with this patient over next 1 year. Similarly, we can also predict the risk of exacerbations or death. If we combine both, again, the current FVC and how the FVC is changing over next 1 year, we can predict the outcomes in using the FVC values. Sometimes we come across the TLC term, total lung capacity, but I will suggest TLC is not mandatory, not required in all patients, because one thing, TLC is not available. The second thing is FVC is a good kind of a surrogate of TLC, and almost all the trials, studies have used FVC as a marker of improvement as well as the worsening. So always use FVC, and truly that is easily available, and there is a good correlation of SCC and TLC. What are the limitations? So in sometimes FVC may not be useful. For example, in early disease when there is only regional fibrosis, it also, there is some data where you see that it do not correlate well with dyspnea, because many times dyspnea is subjective, and I have seen many patients who are having FVC of less than 30%, but still patient never say that I am having dyspnea, although you can see from distance that he is using accessory muscles of respiration, but still they will not perceive because it is subjective symptoms. It is also effort dependent, so patient require lots of good cooperation from the patient before we can complete the vital capacity the maneuver. So that is one limitation, and also sometimes isolation of isolated decline in FVC or change in FVC may not be useful. We should also consider the other changes, maybe in DLCO or maybe six-minute walk test or HRCT. So whenever there is a doubt, please combine all these modalities to reach any conclusions. And I suggested that we should also monitor DLCO, and somebody can say that we are monitoring only FVC, then why DLCO? There is data which suggests that we should monitor both, although physiologically one would expect that once FVC go down, DLCO will also come down. So most of the time it will happen, but there are situations when you will see that FVC has not changed, but DLCO is declined. There will be situation where DLCO is declined, but FVC is also declined. There will be situation where FVC has declined, but DLCO is not changed. So it is suggested that if facilities are there, we should monitor both FVC as well as DLCO. And in next slide, I am showing this. The DLCO alone, or DLCO is independent risk factor for mortality. So DLCO is also useful parameter to monitor the functional status among these patients. So the tip is, many times we do this spirometry and you see the values, and we don't see the other things. We just see the value, what is FVC, 1.5 liters and maybe 50%, but we don't see other details. And we have seen a FVC, this PFT report, where the equation are different. At first time when patient came, we used the Indian standard, and next time patient is coming, maybe European standards or GLI kind of equation. And when we use this, the percentage predicted will be different. So if you are interpreting this FVC value based on percentage predicted, that can be erroneous. So that is one tip. The next tool which is available for functional assessment is 6-minute walk test. Basically, it is a exercise capacity test where we are measuring the sub-maximal capacity. The other part is the cardiopulmonary exercise testing, where we assess the maximal exercise capacity, but here we use this sub-maximal exercise capacity. We usually measure the distance walk, that how much distance was covered by patient in 6 minutes. We also notice the oxygen desaturation, that how much patient had desaturated during the exercise, and also report heart rate and symptoms. So these all can be prognostic marker. And this is very simple kind of a test which can be having good reproducibility and widely used also. And there are very limited kind of instruments are required to measure this. One important point here I want to convey is many times patient is unable to perform spirometry, but 6-minute walk test is a test which can be done in almost every patient unless the patient is having severe osteoarthritis of knees. So this should also be done in almost every patient, and you can follow up based on the 6-minute walk test. The 6-minute walk test assesses the functional status. It gives information regarding disease progression. It also can tell us the response to treatment and also predict the prognosis as well as mortality. So for example, in this slide, I have shown that different studies have shown different cutoffs, but if somebody is having more than 450 or so distance in 6 meters, we consider that he is having probably normal kind of a test. But as the distance covered goes down, it indicates that patient can have poor prognosis. In one study, the authors reported that the 6-minute walk test distance of less than 550 meters was associated with poor outcomes. And if we reduce it further, maybe at 6 weeks down the line, if it was up approximately 200, the chances of death in next 1 year were more than 4 times as compared who are having more than 200 meters. It can also predict the daily physical activity, and also there will be higher FPC or higher DLCO is expected because as the FPC go down, the physical performance status will also go down. And as we discussed, the desaturation is also important factor. If there is somebody is desaturated more than 4%, it can also indicate a future worse prognosis. The 6-minute walk test, then the other things which can also be measured is the different products. For example, NIDR, SPO2 and distance. It can also be measured, and it can also give some information. Then heart rate recovery. It is also a very easy test to measure. At 1 minute, we can assess that how much change in the heart rate was there in the patient. If it is less than 40 beats per minute, 14 beats per minute indicate that there is a poor heart rate recovery, which can indicate a poor prognosis. So we should also know what are the contraindications of this test. Usually absolute contraindications are only few. For example, unstable angina or MI during last 1 month. And there are relative contraindications. If somebody is having tachycardia, uncontrolled blood pressure, in those patients, we can still perform, but these relative contraindications. And as I told, this test can be done in all patients, even if patient is on oxygen. So this is one test I recommend. This should be done in every patient. So there are certain limitations because this test requires some kind of a long unobstructed walking course. It is said that at least 30-meter kind of a distance is required. If 1 lap should be approximately 30 meters. And physical capability of patient. If patient should be able to walk. Then coming to cardiopulmonary testing, I think this is the gold standard of capacity testing, where we can assess the full capacity, and it provides the various parameters. Based on that, we decide that whether this is a pulmonary problem, extrapulmonary, or deconditioning. And most of the time in ILD patient, this is not required. This is only required only in certain conditions. Maybe the patient who are requiring lung transplant and you want to stratify those. Otherwise, in majority of patients, 6-minute walk test is good enough test for exercise capacity testing. So this is what I already told, that if this is mostly not required. Then coming to the next step, dyspnea assessment tools. And since our MBBS class, we are reading this modified medical research counseling dyspnea scale. Then board dyspnea scale is little bit newer one. And then these both can be used, and we can easily track whether the patient is having worsening of dyspnea or improvement of dyspnea. So this is the board dyspnea scale, which is original one, which is on the right side, and then the left side is little bit modification. And the maximum score is 10. The more is the score, worse is the condition. So this can be easily done, but most of the time these are not practical one. So probably MMRC is more easily and more taught and more followed. You can use any of these, but both in the dyspnea index scale is probably more objective and more is a continuous one, so it is easier to apply. What is the correlation between both dyspnea scale and 6-minute walk test? So there is data which suggests that if we see all-cause mortality, it is worse if either or dyspnea or 6-minute walk test is impaired. 6-minute walk test distance or saturation or FPC or TLC, all are correlated with both of these. So, both dyspnea index scale is a useful tool for assessment of dyspnea. Then coming to the quality of life, we have age-old this St. George Respiratory Questionnaire, which can assess the quality of life. It is irrespective of underlying disease. It can be used in any respiratory disease, be ILD, be COPD, or be sarcoidosis. And I think the maximum data is on this questionnaire, which can assess your symptom, activity, and impact. More the score, the poorer will be the quality of life. And there is some little bit of modification of this, which can be used for ILD patients also. Then there are ILD specific questionnaires also there to assess this quality of life. For example, this King's Brief Interstitial Lung Disease Questionnaire, which can also be done. And again, here also the score ranges from 0 to 100. But here it is reverse. The higher the score, better is the health. And for this, there is a cutoff of 5 units change to see that there is a minimally clinically important changes there. And then SF36, which is a again generic kind of a tool which one can apply and assess how the patient quality of life is there. So then there is some composite scoring systems are also there. For example, one index which is gap index, which include the gender, age, and respiratory physiology in the form of FPC and DLCO, and we can put all the values which can give you the prognosis of that patient. For example, I searched it online. It is MedCal. It is online free software. If you put the various parameters, for example, what is the gender of the patient, what is the age, whether it is less than 60 or 61 to 65 or more than 65, like that, and then you put the FPC values and DLCO values, and this software give you the prognosis in next 1 year. So you can use this to stratify your patients. Other tools which has been used but not well validated, for example, 1 minute sit to stand test, which is very easy to do. You can do it anywhere, even in your OPD. Then sit to stand in 30 seconds. Then time up and go with usual pace, your gait speed, 4-meter gait speed. Then other tests, for example, short physical performance battery. All these tests are basically used to assess the patient's ability to avoid falls. So this basically they are assessed for fragility testing. No, fragility testing. But in ILD also, this can give you an idea that how fit patient is. So 1 minute sit to stand test, basically it is a number of time patient can stand from seated position in 1 minute, and there is data which suggests that if less than 30 repetitions, 23 repetitions are there, then it can predict 18-month mortality, and it has a correlation with gap score, MMRC, and 6-minute walk test distance. Although one can say that is just correlation is just moderate, but that it can give some correlation. And if you don't have anything, then at least this 6-minute sit to stand test you can do in your outdoor patient also. So this is my last slide to summarize that the functional assessment in ILD patient is multidimensional, which will include your physiological testing as well as your exercise testing. And spirometry is very, very handy, and it is all of us are well versed with this. We can see the FPC, DLCO, which can see the trend over the time, and 6-minute walk test, which is easy to perform. All these parameters can easily give you the prognostic, short term as well as long term. The quality of life can be assessed any of these tools. I think gap index is very easy to follow. Other tools, SGRQ and K-Build, they are good. They are validated also, but probably it is practically difficult to perform in a PG clinic unless you are doing some kind of research which is directed only to ILD patients. These tests help us in deciding clinical decision, especially how to diagnose this patient or how to subject this patient for further procedures, as well as with these tests we can monitor the progression of the disease. So in clinical practice, we should integrate this PFT finding, exercise testing report, and patient-centered outcome report during management of these patients. With this, thank you very much. And if there is any question or comment, I will be happy to respond.
Thank you, Professor, for the excellent presentation. I think it is one of the very important aspect in the ILD management to have the functional assessment. As he has mentioned, basically the multimodality is important. The most important thing which I want to assert here is that but the good pulmonary function test is as important as we are having good HRCT, has been discussing in the patients of the ILD. So the question is the quality pulmonary function test. Another thing is that probably availability of the diffusion test may not be available everywhere, especially in the peripheral part of the country. But 6-minute walk test, this test, basically this test is very much underutilized. This can be done at any place and has got a good prognostication. And you can assess your patient that whether your patient is doing well or not. And you can basically, one study has shown very clearly, although it was taken from the COPD, that if a patient is not able to walk 100 meters in 6 minutes, the chances of survival is only 20% for 1 year. So in that way, it becomes a very important tool in the hand of the clinician. You have to utilize this in clinical practice very often. And it is very, very underutilized test, a very simple test. Apart from that, the Sanjar, the respiratory questionnaire, actually, and this all these quality of life tests, probably you may not be able to do in the periphery, and it is much more in the research setting. However, most of these tests can be done very often, and it is a very important tool in the hand of the clinician.
It was excellent. I was just thinking,
I think, sir,
muscles, is it important to
so your question is very pertinent, sir. Thank you for asking this. Actually, muscle wasting, if you ask, that is very, very common in all the respiratory diseases, including ILD. Reason are multiple because these patients are taking long-term steroids. And second thing is their physical activity is markedly reduced. Both of this will lead to muscle wasting. But measuring chest muscle, if you talk about this pectoralis measure or like that, probably will not give much information. Maybe peripheral muscles in the form of arm muscle or thigh muscle, or more importantly, maybe respiratory muscle itself, diaphragm, which can be assessed. And with the use of ultrasonography, we can check. And for peripheral muscle, I think change in thickness or maybe area will be more important as compared to single kind of a report. And diaphragm also, you can easily check that the patient who are having diaphragm dysfunction or not, those who are having diaphragm dysfunction, the dyspnea score will be out of proportion to the lung involvement. So that can be very useful.
So the chest muscles are too weak in assessing the pulmonary.
Sir.
Any question from the audience? Okay. We'll close this session as there are no questions.
One question there from this. So thank you for asking this question. So I think there are few indicators which can be there. Maybe if you are performing DLCO, which is out of proportion decrease. For example, somebody is having FPCO for approximately 70% only, and DLCO is 30%. So there is a disconnect. So in those patients, you can suspect that maybe pH is also there. And also when you do the 6-minute walk test, again, if there is a out of proportion desaturation, that can again indicate this patient can have associated pH. Thank you.
That was the master class. Thank you, sir, for the incredible, insightful lecture. Now it's time for felicitation. I request Dr. Mansi Gupta, Organizing Secretary of the CME, Additional Professor, Department of Pulmonary Medicine, to felicitate Professor Vijay Hadda with a memento as a gesture of her gratitude. Let's have a round of applause to them. I request Dr. Mansi ma'am to felicitate Dr. Nitesh Gupta with a small memento as a token of appreciation. I request Dr. Mansi Gupta to felicitate our chairperson, Dr. BP Singh, with a small memento as a token of gratitude.
Next, I request Dr. Sanjay Tandon, sir, to receive the memento as a gesture of our gratitude. Next, I call upon Dr. Pranav, sir, to accept the memento as a sign of our enduring appreciation. Next, I call upon Dr. Abhinav Chaudhary to kindly accept the memento as a token of gratitude.
Thank you, dignitaries. Now we move on to our next session. The next session is my approach to diagnosing ILD, case-based approach. Now, for this session, chairs for this session is Professor Suryakant, Professor and Head, Department of Respiratory Medicine, King George's Medical University, Lucknow. Professor Amitabh Das Shukla, Professor from Motilal Nehru Medical College, Allahabad. Dr. Ashwini Mishra, Faculty, BRT Medical College, Gorakhpur. Dr. Jyoti Bajpayee, Associate Professor, KGMU, Department of Respiratory Medicine, and Dr. Abhishek Agarwal. I would like to call the dignitaries to the dais. Now, I would like to call our organizing secretary, Dr. Mansi Gupta, to proceed with her presentation.
This session is about how we are diagnosing cases of ILD. We have kept the most common etiologies here, and we try to keep it case-based so that you can understand. So in this session, I am talking about hypersensitivity pneumonitis, which is a very commonly encountered ILD. There's a case scenario here. There's a case scenario here. He's a 53 years old male. He's a city dweller and is a non-smoker. He had symptoms for 1 year, very classical symptoms of dry cough for 1 year, and it started developing shortness of breath, which progressed to grade 2 MMRD, and used to complain of chest heaviness. So initially, he went to his family physician and diagnosed with bronchial asthma as the most common diagnosis, because the symptoms typically started in some winter season following a upper respiratory tract infection. And he was started on inhalers. He had some relief, but no complete relief, and he was still worried about his symptoms. So he went to a specialist, that is a pulmonologist, and he was told that you have an ILD, and he was started on steroids. Now the patient was told an ILD, but they don't know what type of ILD they have, and steroids is the go-to treatment for all the ILDs, so it's safe for everyone to start. But it's very important to find out the etiology, and he came to SGPGI for second opinion. Ultimately, lung fibrosis is a very doomed diagnosis for the patients also. So this was a CT scan when he brought his scans to us. And the resident was very happy to work up this patient in our department, and he told me that, ma'am, we have made a high confidence diagnosis of hypersensitivity pneumonitis. Now the case has ended with the diagnosis of hypersensitivity. Now we'll tell you how we made this high confidence diagnosis of hypersensitivity pneumonitis. What exactly is this ILD? This is an exposure related ILD. So you have inhaled antigens, and the person who is genetically predisposed, there's some genetic linkage to most diseases, as is with this case, because same inhaled antigens are causing some interstitial lung disease in this patient. And the susceptible patients will have an exaggerated immune response, which is following this inhalation. And the timeline can be acute presentation or a subacute presentation, or since the patient has been genetically predisposed, or maybe the risk factors have been such that he will develop a progressive or fibrotic disease. Now the risk factors, mostly it's an organic exposure, mostly. So they can be microbial origin, plant origin, avian origin, birds and animals, both. Their proteins, or some low molecular weight chemical compounds. So the persons who are working in certain industries, they can also combine with host proteins, and they can form haptens, which can generate that immune response. Now the exposure can happen anywhere, so it is very difficult to find out the exposure, and I'll tell you why. So it can happen in your house, it can happen in your workplace and your recreational environments if you're going to certain places. It is also postulated that viral infections repeatedly, if you have, and the person again is, those viral infections can heighten the immune response in these kind of patients who have a susceptibility to develop HP. And smoking has a linkage in terms of progressive or fibrotic ILD. What type of immune mechanisms work? Both humoral and cellular. This is not, I will not go into detail of pathogenesis, but residents should know the pathogenesis of HP. Now, when you are going to have such a patient, an ILD presents to you, you should always have a high index of suspicion for hypersensitivity pneumonitis in any newly diagnosed case, especially a person who's having an asthma-like history, which has vaccine-waning course, or a recurrent flu-like syndrome also. And you will need help of not only as a pulmonologist you are involved in the diagnosis, but you will involve a good radiologist. Sometimes there is an overlap with connective tissue disorders and you are confused with the radiology and the presentation. So rheumatologists are needed. And if you decide to go for invasive sampling, then pathology. So MDD plays a lot of role in diagnosing HP. And we follow these targeted steps in terms of clinical evaluation, detailed assessment of the exposure, then looking at the HRCT scans, then maybe, doing additional supportive investigations, which are serum-specific IgG, and BAL and histopathological diagnosis. Now, clinical manifestations, it is more commonly seen in women. We have also observed that association that women are more commonly predisposed to developing HP. Older individuals, usually middle-aged people, 30s to 40s to 50s, and depending on exposure also. And it can be acute, as I said, subacute or chronic. If you have an acute or subacute onset, the symptoms would be most like chest heaviness after a short-term exposure to an antigen, and the temporal association could be very well delineated in such cases. So patients may be giving history of malaise, fatigue, chills, and chest tightness, something like an asthmatic patient for the first time presenter. So asthma diagnosis you make over some time. The patient has variability of symptoms in some years or months. Maybe at least 2 years patients would be complaining of some seasonal variability or those kind of things. But this is after a short-term exposure, but the symptoms might be just like asthma. In chronic symptoms, you have low level of exposure, probably which is persisting for a long time, or maybe in some patients, even the exposure has ceased, but the patient had that kind of a phenotype where he was progressing due to the continued immunological process inside. The chronic symptoms would be dry cough and exertional dyspnea, as is our case. In physical examination, so HP, it's an exposure-related disease. You have inhaled antigen going inside lung. The inflammation is more concentrated in the bronchiolocentric areas around the airway. So it is an airway-centric ILD to start off with in terms of inflammation. So in airway-centric ILDs, like ILDs, you will have crepitation, but since sometimes patients will not have wheezes, the airway component is depicted in physical examination by inspiratory squeeze. And in advanced cases, you may have visceral clubbing and sinus. Exposure to antigens, this is the most important and difficult part for a clinician, how to actually elicit this history of exposure. So you have to actually sit down with the patient for some time, and the exposure has to be identified in terms of where he's working, what kind of a household he's at, the area around his household, any industries, what pets he has in the house, especially birds, and pigeon breeders disease, that is the most common exposure, but the history is very loosely taken. Sometimes that history is not good enough. But believe me, despite all the workup, sometimes in 30 to 40% cases or 50% rather cases, we are not able to elicit any history. This is the most, I think it is very difficult, but just to give you an idea, this is from the guideline. And again, they have said this is not a complete list, but I can tell you, don't need to. This is from the clinical guidelines, which is ATS guideline. And there is a huge list of antigens which can actually cause HP. So if you have evaluated your patient, you can actually go into this list and what kind of industry he is part of, what chemical he is working with, all those things have to be asked in detail. The history of the antigen, most important part is that the strength of association should be good. Patient should be able to correlate his symptoms in terms of the exposures and the temporal association with the symptom development to the exposure till you decide, and the duration of exposure, how consistent the history is. Sometimes those patients, especially in acute and subacute patients, we have a nursing staff working with us who had recently shifted her office to a different setup in the same hospital. And then she started worsening of her asthma, which she was already an asthmatic for many years. And her intensive inhaler therapies were going on already. But she was worsening for these 6 months more than ever. So in that scenario, when we did a CT and found out typical changes of HP, and we found out that she's working in an office which was closed for many years, and it is full of piles of office old files, and those were not cleaned properly. So it was quite moldy to sit in that atmosphere. She could feel it. So initially it started like a flu-like symptom, and she had worsening of asthma, but later on it developed into a subacute picture of HP. And once she sees that exposure, she recovered quite fast. So those things have to be looked into, whether the association is reversible, do you have any specific thing attached to it, and especially the temporality is very important. Second thing, I think in detail, Dr. Zafar has already discussed about HRCT protocol. So you have to follow a proper HRCT scanning protocol, especially in HP, since I've already said it's an airway-centric disease. So there are two types of hypersensitivity pneumonitis. One is non-fibrotic, other is fibrotic variant. So he has discussed beautifully in radiology talk in morning that what are the features of fibrotic ILD. So if you have fibrotic ILD, those features of fibrosis should be present along with the features of an airway-centric inflammation from HP. The two important things that you have to look for is, one is involvement of small airway. How do you look for that? You have to look at small central lobular nodules which are less than 5 millimeters and they are ill-defined. So central lobular nodules, how to pick up? I think residents should learn how there are three types of shadows. When you have perilymphatic involvement where the fissures and other things are involved, and there is central lobular nodules which represent airway involvement, and then you have a random distribution more commonly seen with infection. So that thing has to be looked into. Second is air trapping. So air trapping, how do you see? One is that once the patient has inflammation, it will look like ground glassing on the CT scan, on HR scan. But, so I'll show you the picture here. This is the central lobular nodule point. So first one is central lobular. Can you see those very soft looking nodules in the entire lung on the picture there? That is central lobular nodule. Just these small nodules. All right. Second is ground glassing, and there is a mosaic attenuation where you can see differences in, this is the ground glassing part and this is the normal lung in between. So you have a mosaic attenuation. Some subtle fibrosis has started here. And then there is air trapping. So to pick up air trapping best, you have to actually ask for an expiratory scan from the radiologist. So most scans have to be done in good inspiratory effort to find out the findings of lung. But for HP and to look for air trapping, particularly for airway-centric diseases, you have to ask for expiratory scan where you can see areas of air trapping like these. Can you see this air trapping here? And then if it is more enhanced, you can actually get 3 density sign, which is very specific in a patient whom you are evaluating for HP. This is also known as head cheese sign. So you can see a normal lung parenchyma here, and you can see the trapped lung here, and you can see the inflammation going on in the lung parenchyma. So 3 densities are visible in the same scan. This is a typical HP. All the findings of typical HP are there. As we have discussed, you have central lobular nodules, you have ground glassing, you have mosaic attenuation in this cut, you have triple density sign, and you have the yellow arrows are showing air trapping areas on expiratory scan. How do you pick up expiratory from inspiratory scan? That sir has already told. You can see good inspiration here, and in expiratory scan, the patient has performed a good expiratory scan. You can see from the tracheal diameter there. So that has to be asked for. In fibrotic HP, the component of airway remains the same. You will have features of airway involvement in terms of triple density and air trapping. Central lobular nodules may or may not be visible in a fibrotic HP. But you should have findings of pulmonary fibrosis, post-reticulations, traction bronchiectasis, honeycombing, all those things. And the distribution of HP, how it is distributed, it is classically described as that subacute and acute will present more in the mid zones than the lower zones, and the fibrotic variant is more commonly distributed in the upper lobe. But these were, having said so, even if you have different distributions axially and otherwise, diffuse distribution. Still, the more important components would be small airway involvement, features of small airway involvement, rather than the lobar predilection. That is what we have seen. So this is typical fibrotic HP. Again, you cannot see all those features of small area involvement except that you have a lot of areas of air trapping here. So that is central lobular nodules cannot be seen because of extensive fibrosis, but you have traction bronchiectasis already setting in. A lot of coarse reticulations are there. There's too much fibrosis already, but what is standing out here is that you have a peribronchovascular involvement in terms of the fibrosis that you see here. All right, it is more towards starting and fanning out from the tracheobronchial tree, and triple density sign is kind of there. This CT is also compatible with HP in terms of the history and presence of all the findings that we have seen. Third part is after you get a CT scan, which is the keystone in diagnosis of HP, and you have seen that it is quite corroborative with diagnosis of HP, then should we do these specific serum IgG or the HP panels that are available outside? So there are limitations to the diagnostic utility of such panels, but since they are available, should we use them or not? So if you go by the data, the guidelines suggest that you may use them, but the confidence level on these, the use of these serum IgG markers for diagnostic purpose is a very low confidence thing. But if you have a questionable history, exposures are not, you are not able to find out from the history, then, and your CT is quite suggestive of HP, then a panel might just help you in, putting sort of a ancillary, supportive evidence to your diagnosis of HP. So you may use it in your clinical practice, but with a lot of caution. In a good history, exposure is already there. It is not mandatory to do these panels. When do we do BAL? BAL has a good role in terms of, differentiating it from other types of ILD, especially from sarcoidosis, which is again, sarcoidosis is another disease which may have airway-centric involvement. Difference is sarcoidosis is a multisystemic involvement in many cases, but HP is by and large, it is limited to its pulmonary fibrosis alone. So in such patients, it is seen again, sarcoidosis will have lymphocytosis, but it has been seen in studies that the percentage of lymphocytosis seen in HP is much higher as compared to sarcoidosis. In patients of IPF, the type of fluid that you get, it is neutrophilic as per the study. So if you get lymphocytosis and your differential was IPF, in such cases it will differentiate. So it is only used again as a supportive evidence to HP, not as a diagnostic test that you get, because all other ILDs will have lymphocytosis, even all connective tissue disorders also. So it is not like that you get lymphocytosis and diagnosis goes for HP. The cutoff for this is different in different studies and guidelines. Mostly 20 to 30% is taken as cutoff for lymphocytosis in HP patients. So this is the algorithm that we follow in our OPD, also suggested by the guidelines also. So first you have an ILD detected on CT scan or chest imaging. Then you go for exposure assessment, which requires a lot of time and effort. A BAL as a supportive evidence can be done for lymphocyte cellular analysis. So we are doing BAL here with lymphocyte analysis. And you can also go, so what type of inflammation you get in HP? You get a granulomatous inflammation in HP, which is a very typical type of granulomas. They are loosely formed granulomas. So in certain cases where the diagnosis is still a question mark and the patient is good enough for a biopsy, we do a transbronchial lung biopsy or a transbronchial cryo lung biopsy. If you get an exposure identified, typical pattern, you get an HRCT or a compatible pattern, plus you have lymphocytosis. So you have a high confidence diagnosis of HP. Otherwise, you have to go for MDD, you have to reconsider the history, and probably you have to go for a biopsy. So this is the guidelines, what they say, how do you go for a confidence level in establishing diagnosis. So at the max, without a biopsy, if you have a biopsy supportive of HP and all the findings that you have of typical HP exposures are positive, then you can have a definitive diagnosis. But short of biopsy, you can make a high confidence diagnosis based on the things that we have described, a good history and exposure, an HRCT scan, and BAL lymphocytosis. So this we have already, I think Nitesh has already elaborated much on this, but nowadays transbronchial lung biopsy used to be a blind, the tissue was not sufficient enough. Now cryo biopsies are done more frequently. Vis-a-vis surgical, you get bigger samples also. So the yield is little better in terms of, especially in fibrotic cases, it is preferred sometimes because you don't get many chances to do a biopsy. Otherwise, transbronchial lung biopsy, which we used to do, non-fibrotic cases, it was a good yield there itself. Over surgical lung biopsy, the complication rate of cryo lung biopsy is little lesser. So coming back to this patient, the high confidence diagnosis was because the patient's history, the bile lymphocytosis was present, and this patient was working in a industry. So he was a carpenter, and they were doing a lot of sawdust work. So this was his exposure, which he owned up to. So as you can see, the diagnostic challenges mainly lie in the clinical presentation. The type of CTs are, the variability in presentation is a lot. So you have to be seeing more and more number of cases to be able to be sure that, this is HP. Exposure history is very difficult to elicit, but if you really try hard, you will reach somewhere. Believe me, spend some time with the patient, and a good quality scan, both good inspiratory and a good expiratory scan is much needed for HP diagnosis. You cannot diagnose HP just alone on an expiratory scan. And nowadays, we don't use the term acute, subacute, and chronic hypersensitivity pneumonitis. Now you have to categorize them as fibrotic and non-fibrotic HP, and the prognosis definitely is different in both the conditions with phenotype. Biopsy, it is always better if you are stuck without. So if you are establishing in your centers who are not having all the expertise for biopsy, it is better to take an expert opinion center where they are doing biopsies, especially in cases where you have short of high confidence diagnosis. So if you are on low confidence diagnosis from your side, it's better to take another opinion from centers like SGPJ. Any questions? I think.
Thank you, Mansi. First of all, on the behalf of the chairpersons, I'm really thankful to the Sanjay Gandhi PGI team, initiative of Mansi. So any questions from the persons or the audience?
Yeah.
No question from
I would
audience.
like to ask one thing. Because nowadays we are looking at most of HP because HP is the most common analysis, so the analysis is but basic data is little bit different, and we are seeing more cases of overlap cases of HP also. We are getting a positivity of hypersensitivitis nowadays.
Positivity of
ANA, we are getting.
That
So what
I
is
think
your
we have
comment on
discussed.
it? Should be done or not?
No, basically, ANA profile is being done as a part of workup in all ILD patients, but interpretation is up to the clinician. So this part we have discussed, Dr. Vikas has already elaborated on this one. That all ANA positivity does not signify the patient has some bit of immunological condition. So if your exposure and your CT scanning is more favoring HP, exposure history, then obviously the diagnosis of HP. In such cases, even somehow if so 2 plus ANA doesn't mean anything to me as long as titers and everything are significant and patient has some constituents clinically also in terms of connective tissue disorder. If that is absent, then there are some bit of cases who would need a biopsy to get a diagnosis.
Kind of thing. HP overlay might be.
We are not. We try to refrain from making a diagnosis of HP overlap. We are not usually doing that. Ultimately, treatment remains like you're saying, it's an immunosuppression. But patients for prognostication and everything, CTD-ILDs will go in a completely different direction in terms of the systemic involvement, and they have to be more watchful eventually in future. HP is an exposure-related thing, and that will take. If you tell the patient you have some sort of autoimmune condition, then the focus from exposures and other things is gone. So I think overlap should not be the first choice to make a diagnosis.
Thank you, ma'am.
Thank you.
Is there any question from audience? No. So thank you, Mansi. And I this will be time for Dr. Pawan Singh. Pawan Singh is a young star, vibrant speaker from Rohtak, PGI Rohtak, and he will speak on sarcoidosis.
Thank you, chairpersons. Thank you, organizing team, for inviting me here. It is always a pleasure to be in Lucknow. So the topic that has been assigned to me is sarcoidosis, case-based approach. These are my disclosures. And what we are not going to discuss, sarcoidosis, everyone has seen patients of sarcoidosis being diagnosed with sarcoidosis. Every specialty like hematology, gastroenterology, hepatology are seeing patients of sarcoidosis. So there are some things that we are not going to discuss because it is a very heterogeneous disease. The classical presentations of sarcoidosis like erythema nodosum, Hayford syndromes, mediastinal lymphadenopathies, patient with extrapulmonary sarcoidosis, classical lymphangitic nodules, perilymphatic nodules, and fibrotic stage of sarcoidosis. These are not things that you need to discuss with, and they are most common presentations and most obvious presentation of sarcoidosis. Does not require a very critical mind to diagnose these patients and reach up to the diagnosis. So having said that, let's start with case number 1. A 50-year-old lady, a teacher by occupation, presenting with cough, anorexia, and weight loss for 1 year. No other systemic symptoms, not a diabetic, never smoker, got a chest x-ray done and sputum work down and was started on antitubercular therapy despite having a non-conclusive investigation, and finally she landed up at our clinic. She was having a right perihilar mass. On CT scan, a non-contrast CT scan, there was a mass present in right lower lobe which is extending to the perihilum region. It was a coalescing kind of consolidative mass lesion. Now I treat lung cancer. So for me, this is classical presentation of a lung mass and lung cancer, irrespective of the risk factors present in that patient. And there were classical speculations also present around that this kind of mass. Even there are some satellite nodules present around those lesions. We have to take a biopsy, we have to reach up to the diagnosis and finally treat this patient. To assess the disease extent, whether it is resectable or not, or what other organs are involved, we got a PET scan showed us that there were multiple nodules present in liver, spleen, and abdominal lymph nodes. So any one of you who is treating lung cancer or who is aware about the staging criteria, it is a stage 4 disease. Abdominal lymph nodes is an M1 setting. It is not an nodule. It is not an N3 setting. In addition to this, the presence of liver lesions made it a classical case of metastatic lung lesion. So I discussed with the patient, I discussed with the family that what will our approach will be. We'll take a biopsy, we'll reach up to a diagnosis because she is a female and a never smoker. She will have a high chances of getting a targeted molecular alteration positive, and that way we will treat her. Unfortunately, this is not a curative disease, but still we were hopeful that we will be able to do something good about this particular condition. So our next step, we did some routine blood investigations, which were largely unremarkable. We subjected her to bronchoscopy. We were not able to find anything endobronchial growth, but we did do a radial EBUS guided TBLB, and we took out good chunks of tissue out of the her lung mass. I counseled her for liquid biopsy at the same time. So the turnaround time for the histopathology report to come and then ordering an NGS and getting the NGS report will take around 2 to 3 weeks. So instead of doing this, we counseled her that upfront at the outset before the diagnosis is established, we should get a liquid biopsy so that we'll get some time shortened out before starting a treatment. And even after we have a tissue diagnosis established, it is better to do a liquid plus tissue instead of tissue diagnosis, NGS only. This was with the intention that our main target was to take out the targetable genetic alterations so that you can start the treatment early. So this was our intention, but as it turns out, we were wrong as usual. The histopathology report came out to be a classical compact granuloma with mild fibrosis, no necrosis, consistent with sarcoidosis. So this happens in patients of sarcoidosis. This is one of the atypical manifestations of sarcoidosis. It is good for the patient. That is, she is now does not have an uncurable disease. AS-based consolidations can be seen in up to 10 to 20% of patients with sarcoidosis. Out of these, majority will not have any speculations around them, but that is very subtle feature to differentiate it from lung mass. However, the classical presentation of large masses is very rare for sarcoidosis to present with. It is always better to counsel patient before to wait for the diagnosis before counseling a patient. This is something that the lesson that I learned. Coming on to case number 2, a 52-year-old female housewife by occupation, again never smoker, presented with dry cough for 5 years and breathlessness, which has increased for past 1 year. There are no postural variations. There is no history of wheezing or diurnal or seasonal variations. no fever or any other constitutional symptom. No other features suggestive of connective tissue disorders. She had, in her family, her husband had tuberculosis 1 year back. She has a history of hypertension and hysterectomy couple of a decade back. Clinical examination was largely unremarkable except for the respiratory system where fine basilar crepitations were heard on examination. She was slightly tachypneic and she had mild desaturation on 6-minute walk test. But there is no organomegaly and no other cardiovascular abnormalities present. We got a chest X-ray done, which was showing bilateral perihilar lymphadenopathy and some infiltrates or reticulations present in the lower zones, the bilateral regions. Subsequently, got a CT done. CT was showing mediastinal lymphadenopathy, large bulky nodes present on both sides, and HRCT chest was showing interstitial thickening, ground glassing of vesting, and some areas of mosaic attenuation. So classical case of sarcoidosis, we were ready to treat this patient. And before we started treatment, we did some baseline assessment, 6-minute walk test, which showed mild fall in saturation. PFT was showing obstructive pattern. The life was clear here until this point, and we were ready to take a tissue out of it and treat this patient with steroids, methotrexate, and all those drugs. But however, to our surprise, the Mantoux test came out to be very strongly positive. The Mantoux was almost ulcerating and a good area of erythema. Mantoux test was 14 mm in size. AS was elevated, rest of the biochemical analysis was normal, and ALP was slightly elevated. However, because of this scenario, we were now in doubt whether we are dealing with sarcoidosis or tuberculosis. We did a EBUS TBLB. Now EBUS TBNA was showing non-caseating epithelioid cell granuloma. However, TBLB did not show granuloma. TBLB was largely normal or maybe mild infiltrates only. Non-caseating granuloma, strong Mantoux positivity, 1 year history of increasing dyspnea and history of tuberculosis in her husband. So we started her on treatment. Obviously, because we are from a peripheral center, we do not want to risk this patient by giving immunosuppression. Even there is a slight doubt that she might be harboring tuberculosis. We started her on ATT. However, after 2 months of ATT treatment, her follow-up CT scan was either static or slightly worsened than before. Mediastinal lymph nodes were increased in size, and infiltrates have increased in extent as well as severity. So at this point of time, after 2 months of ATT therapy, we revisited our diagnosis and we stopped anti-tubercular therapy and started her on steroids. In hindsight, we finally labeled her as a case of sarcoidosis, and we gradually tapered steroids. We also started on methotrexate, and she had a dramatic improvement in her symptoms after this therapy, and which was not seen before that. So Mantoux positivity sarcoidosis is uncommon. 90% of the patients of sarcoidosis will have Mantoux negativity, that is 0 mm. However, 10% patients can have Mantoux positivity. In a study that was done from PGI Chandigarh, when a TST was repeated by 5 units TU, 30% of sarcoid patients came out to be positive. And the cutoff did not differentiate between sarcoid and non-sarcoid patients. So it is uncommon, but doesn't mean that patient cannot be suffering from sarcoidosis. Quantiferon gold does not add anything to the diagnosis. So it is Mantoux positivity. If it is present and absolutely all features other than Mantoux positivity are consistent with sarcoidosis, you can label your patient with sarcoidosis itself. Now coming on to the case number 3. A 34-year-old male, a never smoker, is a married tobacco chewer, presented with complaints of jaw pain, oral burning sensation, and swelling in his parotid glands for past 3 months. He was evaluated initially by the dental department and later on referred to our clinic because of some X-ray abnormalities. There is no history of fever, cough, any respiratory symptoms, any connective tissue disorders. He is a known patient of diabetes mellitus, which is poorly controlled, and he does not have a significant family history related to his current illness. For clinical examination, it was almost completely normal. There is no respiratory abnormalities. There are no vital signs that are abnormal. His PFT was also near normal. On evaluation in our clinic, when I saw that this patient was having some erythematous dryness, areas of fibrosed areas in mucosa, which was predominantly dry and were nodular in present. This was present even in buccal areas in labial mucosa as well. For the reason he was referred to us was his chest X-ray, which was showing bilateral perihilar bulky areas, which was confirmed by contrast CT, that is with the presence of mediastinal lymphadenopathy. His lung cuts were showing some areas of mosaic attenuation and ground glass opacities in basal regions. Basic investigations were normal, meant to was 0 mm. ACE levels were slightly elevated, but rest of all hematological and biochemical analysis were within normal limits, and PFT was showing mild obstruction, moderate obstruction. So after this, we got a EPUS done and EPUS TBLB done. Instead of that, we also waited for the report from the dental department, who already had done a buccal mucosal biopsy in this patient. So that incisional biopsy came out to be positive for granulomatous inflammation. In addition to this, because he was a tobacco chewer and we were anticipating that because of that antigen, the local areas can have some kind of inflammation, some kind of fibrosis, and granuloma can be present because of tobacco exposure as well. We went ahead and got a EBUS TBNA done from hilar lymph nodes. We showed necrotizing granulomatous inflammation, whereas transbronchial lung biopsy was showing granulomatous inflammation. So in this patient, what we reached, we made the diagnosis of sarcoidosis based on involvement of lung parenchyma, most importantly, because lung parenchyma is showing granulomatous inflammation in patient who is having significant mediastinal lymph nodes and 0 mm mantle, we can easily label that patient as sarcoidosis. But we were not very sure of the oral involvement. We thought that oral involvement can still be because of his antigen exposure to tobacco. We started this patient on steroids, gradually tapered them. He met a complication of uncontrolled diabetes in this patient because of exposure to steroids. And finally, after 2 weeks of therapy, his oral lesions showed a dramatic improvement. We later on started the patient on methotrexate and monitored his other biochemical parameters. But in hindsight, we made a diagnosis of oral sarcoidosis as well in this patient, because of the main reason of the response to the therapy. So extrapulmonary manifestations in sarcoidosis are very common. Sometimes patient will present with clinically evident involvement of liver, cardiac, neurosarcoidosis, which can be seen in a majority of our patients. In 6% of our patients, though in our last case, there was presence of necrosis in the EPUS TBNA report, but still 6% of the patients can have focal areas of necrosis and they are still classified as sarcoidosis. So in conclusion, which practices will help you establish a diagnosis of sarcoidosis, which will help you to get good amount of tissue that your pathologist can use and label that patient as sarcoidosis or whatever the disease is. So starting with things that do not matter. Needle size, 19 gauge versus 22 gauge does not matter. Cytologist, the classical conventional smears, they are not helpful for the diagnosis and they are extremely unreliable. Pro-core needle versus standard type of needles or any other kind of fancy needle do not add to the diagnosis. 10 jab versus 20 jab versus 30 jabs does not matter. 10 jabs are good enough. Old needle versus new needle also have almost equal amount of your diagnostic accuracy. And finally, 21 gauge versus 22 gauge also does not matter. So these are all the studies that have been done in our Indian scenario in a single center, which have established that it is only the basic technology of using and technique of using EPUS TBNA instead of going into fancy details. So factors that can be helpful in making a diagnosis of sarcoidosis. Using narrow band imaging during EPUS endobronchial biopsy, that they will help you to localize the area from which the biopsy has to be taken so that you can demonstrate granuloma and hence reach up to the diagnosis. Conventional smears with cell block. So additional cell block with conventional smears add to the diagnosis. If the patient is belongs to a economically disadvantaged category, that is poor socioeconomic status, then chances of him or her being diagnosed with sarcoidosis are less. TBLB irrespective of spirometry and irrespective of CT finding. So patient has a normal lung parenchyma, patient has normal PFTs, no dyspnea, and in those patients you take a TBLB and 60% chances are that you will get granuloma, and presence of granuloma in lung add to the diagnosis of sarcoidosis. Finally, positive TST and necrosis on EBUS. The combined these two factors will help you negate the diagnosis of sarcoidosis. So in conclusion, how is sarcoid diagnosed? Sarcoid is diagnosed almost always in hindsight. Thank you so much for your kind attention.
Thank you, Dr. Pavan, for this wonderful presentation. Are there any questions from audience? Yes, sir. Mic, please. Is there any mic?
Factors which affect the what are the factors which don't affect the diagnosis? One thing which also does not affect is the use of suction aid. That also has been published. That has been published from our
So when I search for the literature on sarcoidosis, what I do is I type Doria, S, AU, and sarcoidosis. So I don't need to, but next time I'll keep that in mind. Thank you, sir.
Sir, is there any bearing on, hello? I'm from here. Is there any bearing on bar lymphocytosis and its variant on diagnosis and prognosis of sarcoidosis?
So it has been found to be helpful in diagnosing sarcoidosis, differentiating it from other kind of ILDs. For the management purposes, it is not done. It is also technically difficult to get it done. So hence, it is not commonly used, but it can be used for differentiating, but not for diagnosing.
Any bearing on its variant like CD4 positive lymphocytes or CD8 positive lymphocytes?
In literature, sir, it has been described.
Thank you.
Dr. Pawan, thanks for a nice presentation.
One,
We see
Dr. Ashwini. One question. Mic, please.
So,
can you please repeat, Dr. Rajneesh?
Yeah, when we are suspecting a case of sarcoidosis with some nodules on lung and we are going for TBLB, do we routinely also do mucosal biopsies from trachea or carina, or only when there is some nodularity or bronchoscopy?
So the short answer is that we do. We take TBLB, endobronchial biopsy, and EBUS TBNA. However, we do realize that EBB adds very little to the overall diagnostic accuracy. But because it has been a trend, it has been a protocol, and patient is undergoing a very invasive process. Even if you are gaining 3 to 4% of sensitivity and specificity, it is better to get it done in one setting instead of repeating that thing again. So we do it, but we understand that it has very less addition.
Excellent talk, Dr. Pawan.
Perhaps you take the full thing. Lower area, segmental and subsegmental.
And you have very well presented the case presentation, especially case number 2, which you have presented as a tuberculosis also and sarcoidosis also. So in case of, before considering the sarcoidosis, do you have rule out the brucellosis? And another part B, what is the major difference between the sarcoidosis and tuberculosis, whether CB0 test is helpful or not? Thank you.
So, regarding brucellosis, I personally do not have any experience, but I have read about it that in certain parts of India, it is a common problem and has to be differentiated before starting patients on steroids. Like patients who are presenting with long history of fever, having some mediastinal lymph nodes, having significant constitution symptoms in those patients, brucellosis testing is mandated before starting those patients steroids on any immunomodulation. But in our setting in the state of Haryana, we do not have a high load of brucellosis, so we do not test for it.
Thank you, Dr. Pawan. That was a very nice presentation. I want to ask a question. Suppose we get a patient of sarcoidosis where they've got skin lesions also and pulmonary lesions also. So if you are able to make a diagnosis from skin biopsy, is it necessary to do TBLB or biopsy the nodes also?
Sir, as per the traditional teaching, you have to establish only granuloma in one of the histopathological report, and you do not require repeated lesions. But this happens when you are in doubt whether that skin disease is different and whether is lung disease is different. But if the presentation is classical, demonstrating granulomas in only one histopathology is sufficient.
We are heading toward the next talk. It is my honor and privilege to invite Dr. Sehjal Duria. He's an eminent researcher, great orator. He's additional professor in the Department of Pulmonary Medicine, Chandigarh, PGI, Chandigarh. He had completed his MBBS and MD internal medicine from AIMS, New Delhi. And his area of interest includes sarcoidosis, DPLD, interventional pulmonology, sleep medication. And he had more than 310 publications to his training. He has also authored several books, chapters, national and international books. So welcome you, Dr. Sehjal. I'm eager to listen to you regarding IPF and how to diagnose this disease.
Thank you so much, chairpersons and organizers. So in the next 15 minutes or so, we'll try to go through certain cases of ILD where IPF is a consideration, and we'll try to decide whether the final diagnosis is IPF or something else. And I've taken this caller mic and I'll try to make it a little interactive. I'll come amongst you. So can I see the hands of students, MD and DN student here? Or sitting at the back, Mike, you should be in the front, right in the front. So please come to this block at least. Any others? Students? MD, DN? Okay. So can you give me a slide changer? Reticulation with traction bronchiolectasis, honeycombing, or transglass. Have a hand mic. Honeycombing. Mic, please. Predominantly honeycombing. I agree there is traction bronchiectasis as well as honeycombing. So at the bases, you can see all those completely air-filled cyst-like spaces in stacks of more than 3 or 4, which is called honeycomb. That's correct. What is this? Let's have a look at the CT and move to the question. So which is the predominant abnormality now? Reticulation with traction or honeycombing? Traction or honeycombing or traction? So honeycombing or traction? Just tell me, or reticulation. One of the three. Traction. So it is majority of it is traction. There is no honeycombing. These are all small little bronchioles which are dilated, which is called traction bronchiolectasis, right? So this is the slight difference which we keep on harping about what is probable UIP and what is definite UIP. So the first one is definite UIP because you have honeycombing. The next one is probable UIP because there is absence of honeycombing and there is mostly traction bronchiectasis. But some of the radiologists would report this as honeycombing and they will call it definite UIP. Because sometimes it is really difficult to make out whether this is just traction or honeycombing. And now more and more literature is coming that it doesn't matter whether it is probable UIP or definite UIP. If the extent of these changes which are consistent with fibrosis is too much, the prognosis will be the same. So it's the extent of changes consistent with fibrosis which matter more than a probable or definite UIP pattern. So these are the various kinds of definitions that we use for definite UIP, possible UIP, probable UIP. In 2011, then 2017, we had a radiologist's paper from the Fleshner Society of Radiologists, which had a similar kind of definitions given to these terms.
So now this possible UIP thing has been taken away and it has been replaced just with 4 categories: definite UIP, probable UIP, indeterminate pattern which does not fit into anything, and alternate diagnosis. So previously it was called inconsistent with UIP pattern. Now it is called an alternate diagnosis other than UIP. So UIP pattern is basically subpleural basal predominance, reticular abnormality, honeycombing with or without traction bronchiectasis, and absence of features listed as inconsistent with UIP. So what are the features which are inconsistent with UIP? Ground glass opacity is very good. Consolidation. Tell me next. Nodules. Anything else? Cysts. Anything else? Any particular lobar predominance? Upper lobe is inconsistent. Lower lobe is consistent. Anything else? Yeah. So upper or mid lung predominance, peribronchovascular predominance, profuse micronodules, discrete cysts, segmental or lobar consolidation, diffuse mosaic attenuation, and extensive GGO. So almost you people told all of these, and we can have this mnemonic. Uttar Pradesh is the national capital of chaat and malai pilori, so that you can remember all the inconsistent features. And I keep on changing this mnemonic wherever I move. Okay. So these are the newer guidelines of IPF. As I said, 4 categories: UIP or definite UIP, probable UIP, indeterminate, and alternative diagnosis. So the indeterminate pattern means that there is subpleural predominant and basal predominant ILD, but the reticulation is really subtle. You are not really able to make out whether it is true reticulation with traction or there's just some ground glassing, few little interstitial thickenings, and you are not able to attribute it to, say, IPF. You sometimes feel that is just ILA, interstitial lung abnormalities. So then you say that it may be an indeterminate for UIP pattern. And this is the latest IPF guideline, which is 2022. The thing that they have added here is a level of confidence. So when you have a definite UIP pattern and you have gone through the clinical details also, the final MDD diagnosis in this case will be a confident diagnosis with a more than 90% probability. With probable pattern, indeterminate pattern, and alternate patterns, the probability of diagnosis or the confidence of diagnosis will keep on going down. So once you have a CT finding suggestive of an alternative diagnosis, it becomes a less than 50% probability. So there you should go ahead with, say, a biopsy, at least there. With the indeterminate pattern also, mostly you will go ahead with a biopsy if the other features like age, smoking status are not consistent with IPF. So we begin with the first case. So we had a 62-year-old lady, cough for 4 months, breathlessness was not there, but there were clear Velcro crackles, clubbing was absent. Spirometry was almost normal, or you could say there might be some mild restriction. And then the walk test showed that there is desaturation. So there is some respiratory or cardiorespiratory disease going on, and there are crackles. So what do you think is the first differential in this case? ILD? Okay. Will you think of IPF or a non-IPF diagnosis in this case? Non-IPF, why? It is a lady that goes, like there are more males, like 60 to 70% are males. But what is the age? The age is the most important. So anything more than anybody more than 60, IPF is a definite possibility amongst the differentials. Lady makes it less probable maybe, but it doesn't matter. The gender will not matter finally. It matters only in the final percentage or proportion of patients, but clinically it will not matter much. But a younger patient, a younger woman with some ILD features, there you will think of what other disease? CTD ILD. So here we will have IPF in consideration, but we'll try to rule out other features or other diseases also. So what are the clinical details that we need to rule out causes clinically, historically? So you can remember by CDEF. C is connective tissue disorders, D is important drug exposures, E is environmental exposures, and F is family history. Okay. So here we had some CTD features, some hand joint pains, but no swelling, no important drug exposures. What all drugs will you ask for before diagnosing IPF? Nitrofurantoin, very important. Any chemotherapeutic drug, amiodarone, methotrexate, but methotrexate ILD is very uncommon. So you should ask it to any chemotherapeutic agent like bleomycin, etc. Environmental exposures, she was exposed to pigeons, peacocks, mold, cattle, and a wheat mill, which she used to use at her house. There was no family history. What are the investigations that we do? First of all, antibodies, which include autoantibodies, HB panel. We need a CT, obviously, and we do a biopsy if required. So in this case, the HP panel was all negative. That is Cladosporium, Aspergillus, Micropolyspora, Penicillium, and pigeon. We usually don't give any credence to the mucor antibody, which labs are doing. I don't think there is much of HP due to mucor, which happens in our practice. And autoantibodies were all negative. CT was like this. So what do you see on the CT? What is the lower predominance here? Do you see a definite lower-low predominance? Or the mid zones are also reasonably involved? Mid zones are involved, but still there is an apicobasal gradient. The lower lobes are more involved. Do you see any inconsistent features here? Honeycombing is there possibly, traction is there, reticulation is there, some lower-low predominance is there. Any other inconsistent feature? Yeah, so take a mic in this row. So some mosaic is there, but are you sure of that mosaic? Are you very sure that there is widespread mosaic? Everybody is sure that there is widespread mosaic, or he is sure but you are unsure? Tell me. You don't think that there is much of mosaic. It is almost it is an expiratory scan, so we'll not call it mosaic, we'll call it air trapping. So there should be very, very evident. The air trapping should be very, very evident, but it is not. He is disagreeing with you. Okay, so two radiologists will also disagree in this case. Okay, so we are not very sure about mosaic, but there might be. So there might be some inconsistency, and there is some exposure to all these cattle, peacocks, but HP panel is negative. So we are confused whether this is IPF or this is going more towards an exposure related ILD. To have a closer look at the lower lobes, now there is some motion artifact. So not much of fun in having a closer look here, but still you can see that possibly there is some honeycombing developing here, but only one stack of cysts. So we don't know. So what will you do next? A conventional TBLB, surgical lung biopsy, TBLC, BAL, or just make a diagnosis of probable UIP, IPF, start the patient on antifibrotic, or just make a diagnosis of ILD, NOS, not otherwise specified, and start on glucocorticoids. What do you want to do? That side. Hand. One of you. What do you want to do? TBLC or TBLB? TBLB. Do you disagree or agree? TBLB or TBLC or surgical lung biopsy? First, BAL. Okay, you'll ask the patient to come after 15 days. You'll give a date in a government hospital. You'll just do BAL and send back the patient. And then BAL report will come after 7 days. Then you say nothing is there. Come again for biopsy. What will you do? Suppose it is 20%. What do you do? Will it give you a definite diagnosis? Yeah. So is it better to do a biopsy straight away? Okay, but you are not in just hold it, one of you. You are not in the interest of treating the patient empirically here. Okay, so you are interested in doing a biopsy and or a BAL. So we did a biopsy, we did a TBLC, we didn't do a BAL, and in the report from a non-pulmonary pathologist, we got this particular thing that there are areas of honeycombing scar tissue with mild to moderate inflammation and loose lymphoid aggregate formation. But this pattern was finally reported as UIP because there were certain areas of scar, there were areas of honeycombing, there were areas of fibroblastic foci. So this is all consistent with UIP. It was reported as UIP. But when we discussed it in our MDD, then our pathologist, pulmonary pathologist, clearly pointed out that there were some mononuclear inflammation and peribronchial metaplasia and peribronchial fibrosis, which goes in favor of hypersensitivity pneumonitis. So she said that this is a UIP pattern in a background of HP. So in this case, we made a diagnosis of fibrotic HP with a UIP pattern and not IPF. Okay. So next case, again, 60-year-old lady, cough for 3 years, breathlessness for 2 years, MMRC 2 for 6 months. There is clubbing. There is a normal PFT, and 6-minute walk test doesn't show much of desaturation. So functionally, she is preserved. but she's 60 years, symptomatic for 2 to 3 years. So again, we do a CDEF, nothing, but there is some cattle work history. So there is some environmental exposure. So what do you think? IPF, non-IPF? It's not moving towards non-IPF, so it might be IPF. Age is consistent, but the history is a little longish, and still the pulmonary function is preserved. But some IPF patients may behave like this. So what do? Autoantibodies, ABC, autoantibodies, negative, HB panel all negative. We did a TBLC and we did a CT chest. So what does CT chest show? One of you, please decide. Can you see in these cuts, can you see any abnormality? No. What about these cuts? So there is right lower lobe. There's some left lower lobe involvement also, but right more than left. And there is honeycombing, or it's just traction? Maybe some honeycombing here. I feel there is a lot of traction here, but a lot of asymmetry. Do you see any kind of mosaic or ground glass? Left side possibly, yeah. So probably some mosaic. So what do you do? What do you label this CT? Inconsistent or alternate diagnosis, or probable UIP, or definite UIP? Probable UIP? Maybe probable UIP, or it may be, you may call it indeterminate. There's a lot of confusion here because it is not symmetric. So it may not be a probable UIP. There is some ground glassing. It may be inconsistent. There is some confusion, right? And there is some exposure history. What do you do? So these are the cuts where you can see them better. So it seems that some honeycombing is developing on the right side, but I am not sure. What will you do? Will you label as IPF? It's a 2 or 3 years history also. What will you do? How will you describe the CT pattern? We discussed that it may be any of these, probable or indeterminate. So these are the two which we will select. So what will you do? I did a BAL. Lymphocyte count is 15%. So we went ahead with a biopsy also at the same time. So what do you want to do? Do you want to do a biopsy, or you want to treat the patient empirically as IPF? You will like to do a biopsy because there are certain features which are not going clearly with a clear case of IPF, right? Maybe in a 70, 80-year-old smoker male, you will not do a biopsy. But in a 60 female, longish history, you might do a biopsy. So the biopsy shows a clear spatial heterogeneity. There are no fibroblastic foci, but there is fibroblastic proliferation. So it is almost amounting to a fibroblastic focus. There is focal myxoid change, and it is reported as consistent with UIP. So now are you clear that it is IPF? Because there are no features of intense inflammation suggesting CDD. There are no features of peribronchiolar fibrosis or inflammation suggesting HP. So we have tried to rule out HP and CDD here. So we made a diagnosis of IPF and started her on antifibrotics. So these are the features which we have already discussed. So this is honeycombing, clear cut, lower lobe predominant, subpleural, 3 or 4 stacks of cysts, and this is definite UIP. And what is this? What pattern is this? Definite, probable, inconsistent, probable, because there is mainly traction. Yes. And here it is. No, it is not an SIP. It is not a uniform kind of ground glassing. Is it indeterminate? It is more or less indeterminate. No clear traction is there. Some reticulation is there. What about this? Probable, definite, alternate diagnosis, alternate diagnosis. What diagnosis is primary here? HP is the primary possibility because of lots of lobular air trapping. So the last case, which will rush up in about 4 minutes. 55-year-old lady, breathlessness and dry cough for 10 months, non-smoker, no CTD, no CDE, RFNA negative, spirometry shows moderate restriction. This is the CT. What is the pattern? What are the major abnormalities? That side. Speak up any wrong thing also. It will be beneficial to you. Don't want to speak up. Lower lobe predominant, traction bronchiectasis. So do you believe it is probable UIP or definite UIP? Probable UIP. Okay, probable UIP. You can easily label, but do you think it might be fibrotic NSIP also? Is it possible that this is just fibrotic NSIP or fibrosing organizing pneumonia rather than probable UIP? Is this image consistent with fibrotic NSIP or not? It may be. So we are a little confused between a UIP IPF or maybe a CTD UIP or maybe fibrotic NSIP. And the patient's age is 55. So is it a typical age for IPF? No. So what do you want to do here? CTD markers are negative. What do you want to do in this case? What do you want to do? Balen biopsy, okay. So what surgical, TBLC or conventional? You'll go for a cryobiopsy. Can you do a surgical lung biopsy? Will it be better if the patient is affording, if you have a good surgeon, if you have VATS? I will go ahead with a surgical lung biopsy because if you have a good surgeon, because that will give you a larger tissue and it is best for UIP and NSIP differentiation. If you get a large tissue with SLP, okay, but we didn't have a good surgeon, we don't have VATS in our institute, so we went ahead with the TBLC. In the TBLC, it was reported that the tissue was adequate, but what we got was this kind of uniform expansion of interalveolar septae with fibrosis and mild inflammation, which was labeled as NSIP. Okay. Now, there may always be a sampling error of the biopsy. If you don't have a large biopsy, even an IPF patient may have an NSIP focus. But in this case, because the patient was younger and we got a good tissue, we believed this report and finally diagnosed the patient as idiopathic NSIP. We started her on corticosteroids. This is an old case, so at that time we used to use very high doses of prednisolone, but the FVC did improve by 250 ml. So that's what we thought, that it must be fibrotic NSIP of idiopathic nature, which has improved with steroids. I think we can wind up because there's no time. I had another case, but we'll just skip it. Or you can just have a look at the CT. Low predominant, what is the pattern? Typical UIP, yes, you can say that there is a lot of honeycombing in the basis, but is there any particular sign that you can see? Straight edge sign. So it is suggestive of a CTD related UIP, and so the anti-centromere antibody also came along positive, but there were no clear-cut CTD features, so we went ahead with a biopsy, and we got a fibrotic pattern, fibrotic ALD pattern, but numerous aggregates of lymphomononuclear cells along with areas of fibrosis, lymphoplasmacytic infiltrate. So these two things suggest that there is an underlying CTD, a lung dominant CTD, which might be responsible. So we made a diagnosis of a CTD cause of, and the pattern was more consistent with a fibrosing OP. So we made a diagnosis of CTD associated. So the summary is that if you have clinical features and radiologic findings, if everything is consistent with the diagnosis of UIP, IPF, you can go ahead and treat. But if you are confused, then go ahead with a pathologic confirmation. So if you have a smoker, age more than 60 years, no exposures, autoimmune profile negative, you can straight away look at radiology, consistent pattern, you can treat. But if there is any confusion, go ahead with the pathology and then make the diagnosis. Thank you.
Thank you, sir. That was a very nice presentation differentiating between IPF and other ILDs. So, is there any question from audience? Any questions from audience?
Any questions?
Thank you so much, sir.
Everyone is hungry.
So I just want to ask, because the guidelines say that if there is a definitive UIP pattern, we have to straightforward to start with the anti-fibrotic the please and guideline also added that if the probable UIP pattern, and you have shown so many cases like there is a gray zone when we are getting a probable UIP cases, but still we are doing a biopsy. So I think this is a very important learning point here, because we are looking straightforward to the CT, and this is the probable UIP, we start the anti-fibrotic. Your patient, but you have so many cases. There is a fibrotic NSIP is one of the cause for the probable UIP pattern. So I think the one comment. And
yeah, but I didn't show you a typical case of IPF UIP. Suppose a 70-year-old smoker comes to us and he has a probable UIP pattern without any inconsistent features, we'll diagnose that patient with IPF after doing a symptom screen, an examination for CTDs, and then an basic autoimmune panel, and we can straight away label as IPF and start on antifibrotics without giving any steroids.
Yeah, so history is very important. History and age factors are very important to diagnosing the disease.
So if there are no any questions any further, so you can wind up this session. I would like to thank all the eminent speakers who have talked beautifully about the various common lung conditions and to how we can precisely diagnose them. Dr. Mansikta madam talked excellently about fibrotic and non-fibrotic HP and the usefulness of BAL and transbronchial lung cryobiopsy in many of these patients. Dr. Pawan Singh also helped us in diagnosing and approaching the sarcoidosis patients who sometimes present with Montaux positivity and the TBNA sample or the transbronchial lymph node TBNA sample comes out to be shows necrotizing granulomas. Then how do we approach these cases and make a final diagnosis of sarcoidosis in these cases? And as usual, Dr. Sajal Dhuria sir lecture was very interactive and excellent, and I thank them all. Some of them have come to this place from very far off, and it's a privilege for all the PG students and for all of us that they have traveled so far to this place and delivered such excellent lectures. Thank you, sir and madam. Thank you so much.
Thank you for this robust clinical presentation and approach towards case-based discussion. Now it's time for the felicitation. I would like to call upon the stage our scientific advisor, Professor Admal Khan, Professor, Department of Pulmonary Medicine, SGPGIMS, for the felicitation program. First of all, I will call Dr. Mansi Gupta to the stage for the felicitation.
almost.
Now I would request Dr. Pawan Kumar Singh for the felicitation program. Next, I would request Dr. Sajal Dhuria for humbly accepting this token of appreciation. Now it's time for Professor Surya Kant for the felicitation program. Professor Amitabh Das Shukla. Dr. Roshini Mishra. Dr. Jyoti Bajpayee ma'am. And lastly, Dr. Abhishek Agarwal. As we conclude the session,
How is it?